join this feast of imaging in GI and hepatic radiology. Without wasting much time, I want to thank all the speakers and moderators and panelists to be here to share their experience with you, and of course GE Healthcare for organizing this in collaboration with Max Healthcare. So I will pass on the screen and the mic to Aishwarya, who is the Chief Coordinator, to take it from here. Thank you once again.
Yeah, very good morning, everyone. Thank you so much for joining the webinar. The topic of the webinar today is Liver Elastography-Integrated Clinical Radiological Approach to Chronic Liver Disease. I am Aishwarya. I head the marketing division function for the ultrasound business at GE Healthcare. And I'm very excited to have all of you on this first of its kind webinar, which is bringing together experts in the care area of gastroenterology for a healthy discussion between the physicians and the radiologists on the needs and solutions in liver elastography. So welcome everyone. What I'm going to do next is I'm going to introduce the host of speakers and experts who will be talking to all of you this morning. First and foremost, from the Department of Gastroenterology, inviting Dr. Vivek Raj, who's the Principal Director and HOD of Gastroenterology and Hepatology at the Max Superspeciality Hospital and the Max Smart Hospital. He is an MD MRCP diplomate in gastroenterology from the American Board of Internal Medicine. He brings fellowship in gastroenterology from the Boston University. He has close to 15 national and international publications, being part of 24 odd clinical trials, and he's held professor roles in the University of Arkansas. He's also started the Max, he's been a key part of the start of the Max Institute of Gastroenterology. Following him would be Dr. Dhar, Dr. S.S. Dhar. He is Associate Director of Gastroenterology at Max Healthcare. He is a MD, DM in Gastroenterology from SGPGIMS, and he's worked as the Assistant Professor in the Ramaya Medical College, Bangalore. I would also like to bring in our experts in the field of radiology, respected within that field, and within that community to a great extent. So calling on Dr. Chander Lulla, consultant sonologist, fetal medicine specialist from RIA Clinic. He's also the head of the ultrasound department at Jaslok and consultant radiologist at the Reliance HN Hospital. He is MD and DM and brings over 20 years of clinical experience in radiology. He has publications of over 50 odd national and international publications. He's the ex-president of IFSAM and he's currently the dean at IFSAM. Dr. Nidhi Bhatnagar, I would like to invite her. Again, a key player within the radiology community. She is the principal consultant radiology at Max Multispecialty Center, Panchsheel. She's the vice president of the MUSC Society, Musculoskeletal Ultrasound Society. She brings to 20 years of practice in radiology and she's held positions of professor in international universities. She's an MD and postgraduate diploma from Apollo Hospitals. She has a number of national and international publications, founded Society in Musculoskeletal Ultrasound, and she's been the joint secretary at the IRIA Delhi chapter. Following on will be Dr. Abhishek Aggarwal. He is a senior consultant at the Max Superspeciality Hospital, Saket in New Delhi. He is MD, DM in radiodiagnosis at BJ Medical College. He has held teacher positions at the BJ Medical College and has a number of national publications. So with that, with a host of great experts in the field of gastroenterology and radiology, I would like to start the webinar today and I would like to invite Dr. Dhar on the first topic. Thank you.
Thank you, Aishwarya. A very good morning to everybody here. So I have been asked to kickstart, and the topic that was given to me was clinical and diagnostic parameters of cirrhosis, basically to lay the base. So I've tried to go into that direction, and I've called the topic cirrhosis basics. So coming to the first slide. So we all know that cirrhosis is basically a liver disease. It's a generalized liver disease, and it's a chronic generalized liver disease. And when we say cirrhosis, we sometimes use it interchangeably with chronic liver disease, but cirrhosis specifically should mean advanced chronic liver disease. And it is basically characterized histopathologically. So we are basically talking about fibrosis, a breakdown in the structural component of the liver, which will lead to decrease in hepatocellular mass, thus function. And this can present with myriad manifestations, complications, and a lot of them can be life-threatening. So, just a moment. So, carrying forward, this is just to give you an idea of what I'm talking about, the histopathology, the pathology of the liver per se. This is what a normal liver looks like. And this is what a diseased liver looks like. This is a micronodular cirrhosis. This is what it looks like. That's a macronodular cirrhosis. So, coming to the epidemiology of the disease, so we see this quite often that patients come to us with advanced liver disease. They have ascites, they may have a GI bleed, or they come in hepatic encephalopathy. And we tell the family, oh, you've come late. This is acute and chronic liver disease. We are basically coming to the end stage liver disease situation. And they tell us, we didn't know, hame to pata hi nahi tha, we had no clue. So that is a problem with cirrhosis. A lot of patients are asymptomatic. As high as 40% patients are asymptomatic. But remember, cirrhosis is a killer. It's the 12th leading cause of death in the US. And even in India, out of 100,000 deaths, 22.2 can be attributed to cirrhosis. So, as I mentioned at the beginning also, cirrhosis is basically advanced chronic liver disease. Cirrhosis is chronic liver disease, but all chronic liver disease is not cirrhosis. And what is it characterized by? It is basically characterized by bridging fibrous septa. Here it will be a good thing to remember the hepatic lobule with the central vein and the portal triodes at the ends. And in cirrhosis, what happens is, because of the hepatocellular injury, the fibrosis starts to set in. The fibrosis may be portoportal or venomedular from central vein to central vein, depending upon the kind of the etiology. So, cirrhosis, like a cardiac cirrhosis, would most likely lead to a venomedular kind of fibrosis. But when the fibrosis advances, then the structural damage is complete, and it is very difficult to say that this is the kind of fibrosis that has happened. So, what happens is hepatocellular death. When the cell dies, the body tries to regenerate. It tries to regenerate the structure by getting more collagen in, by trying some changes in the extracellular matrix. And if the injury keeps on occurring and the regeneration cannot keep up with the injury, so it ends leading to fibrosis. So a lot of chronic inflammatory mediators are implicated here: TNF, lymphotoxins, interleukins 1. Hepatic stellate cells play a big part in leading to fibrosis. And a lot of toxins can directly affect the hepatic stellate cells and then trigger fibrosis. So although this slide basically is non-alcoholic fatty liver disease, but the only reason I put this slide here is to give you an idea of how it progresses. So from a healthy liver, we have gone to a hepatocellular carcinoma. So initially there was steatosis, then inflammation happened. We came to non-alcoholic steatohepatitis. So the damage and the toxin or the injury, whatever is the cause, this is NAFLD, but whatever is the cause. So it went on unabated and we reached cirrhosis. And if cirrhosis kept on like that years, it can lead to hepatocellular carcinoma. So coming to the etiology, the important etiologies for cirrhosis are alcoholism, the chronic viral hepatitis B and C, although with a very potent vaccine and great treatment for hepatitis C, these causes should increasingly become less important, but unfortunately, that's not the situation so far. Autoimmune hepatitis is an important etiology. So is non-alcoholic fatty liver disease, especially in the bubble that we deal with. We work in corporate hospitals. We deal with a certain affluent class of society. So the bubble that we deal with, non-alcoholic fatty liver disease, is an important pathology. Then etiologies like primary biliary cholangitis, primary sclerosing cholangitis, autoimmune cholangiopathy are important. Cardiac cirrhosis, Budd-Chiari, inherited metabolic syndromes, hemochromatosis, Wilson, alpha-1 antitrypsin, galactosemia, tyrosinemia, very uncommon but there. And then this entity called cryptogenic cirrhosis. We're increasingly understanding that what we used to call cryptogenic cirrhosis is, in fact, a lot of it is now we know it is non-alcoholic fatty liver disease, but there are still some patients of cirrhosis in which we cannot describe a cause, and we call it cryptogenic cirrhosis. So coming specifically to the pediatric population, so Wilson disease is an important cause, biliary atresia, extrahepatic biliary atresia, autoimmune hepatitis, inherited progressive cholestatic disorders like FIC1, FIC2, Byler's, Alagille syndrome, they are important, and then cryptogenic cirrhosis. So clinical features. So as we mentioned in a slide before also, that patients can be asymptomatic for a very, very long time. The onset of symptoms can sometimes be abrupt, like an acute and chronic liver disease situation, or sometimes it can be insidious, some discomfort, some problem, little jaundice. And the symptoms can be very vague. There can be some discomfort, some nausea, some diarrhea, a primary health package done, a preventive health package done, some tests done for some other condition. Some patients can present with more specific complications like ascites or upper GI bleed and things like that, hepatic encephalopathy. The various signs, these signs primarily depend upon the etiology, but they can be alopecia. Icterus is common to a lot of patients with cirrhosis. Pallor is also there. The KF ring is more specific to Wilson disease, pyroid enlargement to alcohol-related liver disease, Peter hepaticus, spider nevi, gynecomastia, wasting of muscles, glossitis, cheilitis, Palmer erythema, clumming, ascites. And when we palpate, we, in a lot of patients, find a firm liver mostly, sometimes a hard liver, but a hard liver gets an antenna up, and we want to rule out HCC in those patients. Splenomegaly is a very, very common finding. And a lot of patients with ascites, tense ascites, we find a lot of caput medusae in those patients, veins radiating out of the umbilicus. These patients also have bleeding tendencies, and the reasons can be multifactorial. One, liver is a factory for factors. So a lot of factors, the clotting factors are made in the liver. So the factor deficiencies lead to bleeding tendencies. Then hypersplenism because of splenic enlargement will lead to thrombocytopenia, and that can also lead to bleeding tendencies. Hyperpigmentation, pedal edema, delirium, and a lot of patients who have minimal hepatic encephalopathy can actually have constructional apraxia, flapping tremors, inversion of sleep rhythm. These things are also in manifest hepatic encephalopathy, but a lot of patients with minimal hepatic encephalopathy can present with constructional apraxia. They can go to neurologist actually. He confused, samajh nahi aata, things like that. So these are just some pictures I know most of you have seen these pictures, these bad pictures of this woman with a large ascites and this gentleman with Palmer erythema on the hands, which is something which is more common in patients with alcohol-related cirrhosis. So, although I know Dr. Raj will be taking these things in more detail, but a primary basic workup like a hemogram, a smear, and INR to look for the clotting, an LFT, hepatitis profiles, alpha-fetoprotein to rule out HCC, a sugar exam, a cytic fluid examination, an ultrasound, maybe a CT scan if we are strongly suspecting a hepatocellular carcinoma, and then trying to make a pathological diagnosis, trying to make a histopathological diagnosis, that's what I mean. So the ideal would be to do a liver biopsy, but increasingly liver biopsy is a procedure with its own problems. That's why we have gone to these new things, the fibro tests, the fibro scans, things like that. So that is where we try to fill in that gap. The complications of cirrhosis can again be life-threatening, as we mentioned before. So patients may have varices. Patient can come with a major bleed. Portal hypertensive gastropathy can lead to, again, a mild ooze, significant anemia, splenomegaly, hypersplenism. Patients may have large ascites, which can cause respiratory distress, but then they can also have infection in that ascites, something known as spontaneous bacterial peritonitis. Kidneys can get affected because the circulatory changes, leading to a type 1 or type 2 hepatorenal syndrome. Patients can have encephalopathy, hepatopulmonary syndrome, portopulmonary hypertension, and most of these patients are malnourished. There's something like a Spider-Man kind of a body. They have a huge abdomen, distended, and the limbs are very thin because of the muscle wasting and all that. It's like a spider kind of a body habitus that they get into. So, hepatoma is also an important complication, as we spoke about. Long-standing cirrhosis, the risk of developing a hepatocellular carcinoma is very high. And we have already spoken about the hematological complications. So here, although Abhishek Aggarwal is the right person because he keeps on doing these liver transplant, post-liver transplant imagings, but since Dr. Nidhi wanted me to mention it, so I'm mentioning it here, that post-liver transplant, when a patient goes to a radiologist, so there are three kind of complications that we basically want to look at. So there are the vascular complications, the biliary complications, and then what we call the other complications. So hepatic artery thrombosis, portal vein stenosis, IVC stenosis, thrombosis, biliary complications like a leak, a stricture, a stenosis. These are important things for which we need a radiologist to help us. And for a vascular, suspected vascular complication, a Doppler ultrasound is usually the first investigation that we ask for. We may need an MR angio or a CT angio, and then a conventional angio if we need to do something to the thrombus. Biliary complications also, we usually start with an ultrasound. We may want a MRCP. For a bile leak, we might want a hepatobiliary scintigraphy. And for a bile leak or a biliary stenosis, the treatment can range from an endoscopic retrograde cholangiopancreatogram to a PTBD, a transhepatic cholangiopathy. So this is more or less that I wanted to talk about. I just wanted to set a base so that the other speakers can take it up from there. But ending with the spirit of inquiry, this is my question for the audience. What is the leading cause of cirrhosis in India? The options are hepatitis B, hepatitis C, alcohol, and non-alcoholic fatty liver disease. And just want to tell you that I'm talking about cirrhosis, not chronic liver disease. Thank you.
So all of you audience, you have 1 minute to answer the poll question. Please go to the poll tab on your screen and you can answer this question. We will show the results in a short while.
So I'll stop sharing now, Aishwarya, if that's fine, okay?
Yes, thank you, Dr. Dhar.
Meantime, Dr. Dhar, that was a great presentation, and I do see that that pediatric part is something. Dr. Dhar.
Yeah, I'm here, Dr. Nidhi. I'm here.
Oh, yeah. Thank you. That was awesome. That was really great. Are we ready, Aishwarya?
Yeah, the tech team, are we ready with the results? Tech team?
Dr. Nidhi, you was sorry, Dr.
Yes,
Nidhi, you were saying something about the pediatric, yeah.
Yeah, the pediatric part. I'm sure there will be questions. Oh, let's go on. Then we can discuss it in the panel discussion. I thought we'll just utilize that time. Right.
I think they've got it right, most of them. The leading cause of cirrhosis is alcoholism, although the leading cause of chronic liver disease is still hepatitis B in India, but the leading cause of advanced chronic liver disease or cirrhosis is alcoholism in India. I think that is, most of them have got it right.
And what about the 29.2, Dr. Dhar? Would you like to comment on that? That NAFLD probably.
So I think like us, they also work in a bubble.
But I'm sure.
It's an increasingly important cause of chronic liver disease in India now.
Yes.
Increasingly important, especially with the change in lifestyles. And we're becoming more sedentary, more prosperous, which is a good thing. But these are diseases which come from that part of the spectrum. So NAFLD is a very, very important cause in the West because viruses are not that important in the West anymore. Hepatitis B, C, they're not that important in the West anymore. Alcohol and NAFLD are. But NFLD, I think Dr. Raj might correct me, it may be the most important cause of cirrhosis in the US, NFLD, but I don't know, Doctor. I think I'm right. So
Right.
increasingly so with the change in lifestyles and increasing prosperity, I think we are going to be seeing more of NFLD and everything else is going to go down. Maybe alcohol we cannot change. Maybe alcohol is going to stick somewhere near the top, but NFLD is surely going to catch up.
After the last budget, I think it's going to be NFLD.
But if you had to look at once the lockdown was lifted, the first thing that
Yes.
opened up was alcohol. So, so I think it will remain the pride
I
of
got that
place.
point. But on a serious note, I think you would put down alcohol as the leading cause of chronic liver disease.
Yes. And I think most of them have got it right. Yes.
Yeah, and it was a good point that you said that you were talking chronic liver disease and not cirrhosis. That's a really bottom line which should be addressed when we are talking about the causative reasons.
Yes.
Right. Okay. Thank you very much, Dr. Dhar.
Thank you, Dr. Nidhi.
Thank you so much, Dr. Dhar. We'll have Dr. Nidhi to talk to us about techniques in liver elastography. So over to you, Dr. Nidhi.
Thank you. Thank you very much, Aishwarya. Are you able to see my screen, please?
Yes, Dr. Nidhi, we can continue.
Perfect. So, welcome everyone to this webinar on liver elastography. And thank you, G, for collaborating with Max Healthcare, bringing this galaxy of strong faculty from the gastroenterology department and us radiologists on the same platform to discuss the applications and the efficacy, which is more important, of ultrasound-based liver elastography as a non-invasive tool in fibrosis assessment. Now, I think the one thing that on which we all can agree very clearly is that the degree of fibrosis is the single most important evidence-based predictor today in management of chronic liver disease and probably progressing on to cirrhosis. What we need to understand, which Dr. Dhar has very nicely elaborated upon, is that first is that the liver disease sometimes and often could be without symptoms. And the symptoms could be sometimes so variable that in order to categorize that, we would need some sort of a definitive investigative tool. The second is that it is very common to learn that the patient sometimes is into the stage 4 fibrosis or impending cirrhosis as the first warning, particularly in our country, where they don't go for the regular health checkups. And last but not the least, cirrhosis. We're talking cirrhosis is not reversible. Now, this is a point where we find that early quantification and differentiation between the early stages of fibrosis, we're talking the early stages where we can make it reversible, carries a significant prognostic implication for the risk stratification from the point of view of the clinician and the patient management, where it brings the clinician and the radiologist or the investigative persons together. Here, Dr. Dhar has elaborated pretty well on the causes of NAFLD and, of course, the prevalence and rest of the details. My only request is to draw your attention here how this flowchart works. And it's just kind of very complex. Fatty liver disease, NAFLD, alcoholic liver disease, which one preceding to NASH, going on to fibrosis, cirrhosis, portal hypertension, malignancy. So where do we start the investigation so that we have an effective management, less morbidity and mortality when we come to chronic liver disease? So, liver biopsy has always remained the gold standard. We all agree. And we were having this discussion where we thought that liver biopsy should be the epitome of all investigative tools. But we all know that there is a downside. Apart from all the complications of the inherent invasive procedure, one of the major things is that a liver biopsy just takes on 1/50,000th of the liver size or the volume that is being taken. And we all know that fibrosis is something which is very unevenly distributed. So this could result into the inter-observer variability, sampling errors, hence accuracy of the liver biopsy that we are taking with so much stress. And last but not the least, it's kind of impractical procedure for a long-term monitoring of CLD. However, one point that I would want to reiterate here is that biopsy does become mandatory or an essential part of the investigation if we are dealing with something which is inflammation, non-alcoholic steatotic hepatitis, which we call as NASH. We come to the ultrasound part of it. Ultrasound assessment of steatosis, which is the first part. See, we are having today, I don't know with everyone, but today out of 100 patients that we are scanning, at least 90% go with fatty liver. And we are really not putting emphasis on how do we qualitatively, there is no quantification, which is, of course, the first step in diagnosis of fatty liver disease. It is subjective, and somehow there is no standardized measure of echogenicity. However, on grayscale imaging, it is important that we reach, as radiologists, some sort of consensus so that by way of grading, a qualitative response can be given in order to credibility to that presence of fatty liver. So grade 1 has been defined as mild steatosis, and this is where the liver shows bright, homogeneous, raised parenchymal echogenicity with round, smooth surface and contours instead of sharp ones, as you can see here. So, of course, the normal one and a fatty liver here. Apart from that, we see that there is attenuation of the intraparenchymal vessels. The intraparenchymal vessels, as you can see, complete attenuation, which gives kind of characterless appearance to the liver due to increased interfaces. And these are created by the fat droplets that accumulate in the hepatocytes. Then, as it progresses and there is more fat deposition, there's a progressive decrease in the ability of the ultrasound waves to penetrate the deepest structures, and that we're talking about the right kidney and the dome of the diaphragm. So once we reach this stage and we are still able to see the porta, we say it's grade 2 FLD, but the grade 3 is where, of course, we can't see very clearly the right dome of the diaphragm, or we are unable to really penetrate through the right kidney. We are unable now to see the porta structures, and there's this sort of thing in our eyes. You know what? I can't see what's behind, lying behind this gallbladder. Portal walls, the portal vein walls are indistinct, and that's when we should grade it qualitatively as a grade 3 fatty liver to indicate to the clinician where are we standing with respect to that one simple caveat that goes in the report, fatty liver. So there has been a constant need to bring non-invasive modality to compensate for the complications of liver biopsy. And the most popular that was put into practice was transient elastography at one point. It has its downsides because it is a unidimensional M-mode-based technology. It has, of course, high maintenance and has its own limitations with ascites and obesity, apart from the other ones. We are not here to discuss or downgrade a modality. We're just discussing the pros and cons of where we should be with respect to a good, robust investigative tool. The second, of course, is the magnetic resonance elastography, the cost, signal-to-noise limitation, time, artifacts. These all go somehow against, even though it gives a very high quality of response when it comes to fibrosis. But these are the limitations that MRE does suffer, and that is when it was brought the ultrasound-based liver elastography, also called as the shear wave elastography, and earlier, of course, referenced very commonly as RFE. So shear wave elastography is two kinds. There is a two-dimensional shear wave elastography and point shear wave elastography. Now, these are two differences in the techniques where we bring out the results in just a different manner. The physics, the basis of the physics of generation of shear wave to give us the elastographic module is exactly the same, except that the vendors have taken two different protocols to give us the results of the elastographic fibrosis in a different manner. Let's touch upon the basis of the physics. It's in very short since we have time limitations. So I'm just going to go over. It started with RFE, which we also called as acoustic radiation force impulse. And this was initially created, which was a linear unidirectional propagation of a pulse wave. It was a push wave which would linearly move across the area that needs to be insonated. And then came shear waves. And these shear waves were generated in the same manner. That means using the acoustic radiation force from that focused ultrasound beam right here. But what modification was done was that at multiple levels of that propagation, perturbations were created. What this led to was that instead of a linear force, we were having also transverse vibrations that were being created. And these transverse vibrations, as you can see here, instead of a linear one here, a transverse was created, and these transverse vibrations then were interpreted by the ultrasound machines. And this perpendicular propagation through the tissues using Doppler-like technique and measures was then interpreting this tissue displacement and helping establish the linear velocity and the elasticity index in Young's modulus and the linear velocity in meters per second. So this is the short of the entire process of how the shear waves interpret the elasticity index of a tissue. Now, these are just two differences between the point shear wave elastography and 2D shear wave elastography, which you may be interested in. Point shear wave elastography, we have 10 breath holds. Now, breath hold is a misnomer here. We are having suspended respiration. So 10 times the patient is asked to suspend the respiration so that 10 regions of interest or the boxes are created. And then there is a one reading for each ROI, which then in the post-acquisition tool is created for us to give the interpretation of the elasticity index. Whereas in two-dimensional shear wave elastography, there is just one suspended respiration, so that a one box or region of interest is created, and in that one region of interest, you take readings, and then, of course, you interpret the findings. So that's the basic difference between point shear wave and 2D shear wave, but ultimate result is just the same for the both. And this is important for us to understand that for a long time, it was assumed that we were dealing with elasticity in Young's modulus, that means kPa, but now it is universal that it has to be a standardized reference which should be given in velocity, which is in meters per second. Yes, you can say kPa, Young's modulus this one. But if we are not including the velocities, we are really not doing justice to our investigation. So to the indications of shear wave elastography, these are to screen the patients for non-alcoholic fatty liver disease, which come in our routine exam of ultrasound whole abdomens. What is it for? For early detection and fibrosis staging, which may lead to chronic liver disease or cirrhosis. Then, of course, there is a difference that has to be created between between the compensated advanced chronic liver disease, which has to be understood as a concept which is coming in very strongly, where the patient is asymptomatic but still harboring all the signs of a chronic liver disease, but is compensated, or there is a decompensated one, which we can do with shear wave elastography. In presence of cirrhosis, which is already established, we have to establish the priority of therapy, follow-up of previously diagnosed fibrosis, assessment of the patients with known cirrhosis for what we call as the clinically significant portal hypertension in clinician's perspective, evaluation of the patients with unexplained portal hypertension. You don't know the reason. A patient is coming with a spleen, a little enlarged liver, and of course the ascites. And last but not the least, the follow-ups which are very easy to assess the response to the treatment, and that is the entire spectrum of the indications where shear wave elastography can help in the management of chronic liver disease. So before we go on to the technique, I'd like to draw your attention to some important terminologies that we use whilst doing liver elastography. Images using these adjustable regions of interest, these are called as the Q boxes, and they have a color-coded stiffness map here within that you can see. Every color pixel displayed within the box has a very discrete confidence value, which is ranging from 0 to plus 48 or above, that can be seen in this reference elastobar. Now, each pixel can be evaluated, but God, it's going to take or ever. So for the ease of time and interest, these small areas, can you see these small rings? These are called as the sample points. And these are selected. They can be as small or as large as 2 centimeter as you would want. And these are then assigned to this color code box. 10 are the optimum. There are studies which say 4 are enough, or there are ones which say 7 are enough, but studies after studies have said that a robust study is where you have at least 10 of them. For every patient, 2 to 3 such Q boxes or the ROIs should be acquired in segment 5, segment 7, and segment 8. Classically, they say segment 8 is good, but this is just a practical tip over the period of time that I've been doing elastography. It always helps me. If I take multiple from 5, 7, and 8, it is like almost replicating a biopsy sampling. Then, of course, after you've taken these samples, this is what the post-acquisition tool is there, which is there in every ultrasound machine, coming through every vendor. And these include the ability to analyze all these values that you've taken, which of course keep showing on your screen as you keep popping these sample points. And these results then can be correctly interpreted. 10 samples and the individual averages of the results are howsoever number of times you've taken. These averages are displayed in the post-acquisition tool, which gives you the exact interpretation finally for making a good report. So let's have the question. Aishwarya, are you ready? Let's see how prepped we are and how many of us are already really keen liver elastography practitioners or maybe wanting to do. Let's see and have a question here. How much fasting is required for liver elastography? 2 to 4 hours, 4 to 6 hours, or 6 to 8 hours? Our team, are we ready for the poll? Can we start the poll, please? A request to all the attendees, please do go on your poll tab and see if we can, 1 minute to you. Perfect, thank you so much. I'm sure it's an easy one and you can get it. And through our discussions, when we are going to have the panel discussion, we will be discussing why it should not be less than something or greater than something, because each one has its own downsides whilst taking a good study pattern. It's a sensitive investigation, and we've got to be absolutely careful when we are dealing with. It's not like a whole abdominal ultrasound where, you know, you can have the patient coming 2 hours after fasting or 10 hours. It is important that we adhere to a very strict regime of having the fasting and properly patient in a proper prepped condition. I was just wondering, are we? Wonderful. Can we have it for us as well as for the audience? 6 hours. We are really good here. Thank you very much. It is extremely that we are really in good space. For the people who have voted for 2 to 4 hours or 6 to 8 hours, we will definitely have a discussion on this, why we cannot have it like overnight fasting. We can, but why we wouldn't want to do that, or less than 4 hours. Actually, the exact, if you have to give you just one value, they say 4 hours. We should have a fasting patient for 4 hours, and that is a great one. So let's go on. Thank you very much. If you could just remove this, I'll go on to my next slide. Oh, right. Oh, that's the reason why you were asking me. Okay, so I go back. I need to share again. That's a lot of loss of time. I wish I knew. I wouldn't have done this. We would have just done at the end. Okay, so I need to share my screen again. Ladies and gentlemen, I'm really sorry about this. So we will not have that poll again. We'll have it at the end. Are we good and ready? Can you see my screen? Thank you very much for bearing with me. All right, so now we go on to the final technique, and it's important that the measurements for the liver stiffness in shear wave elastography are performed through the right intercostal scan, as you can see in the image here. The patient can be in semi-left lateral decubitus or in supine with 2D convex multi-frequency probe, and in the anterior axillary line, 7 to 9 centimeters, absolutely perpendicular to the skin surface. Since the window gets better if the intercostal spaces are widened, the arm is in hyperabducted position, which helps in a great screen showing the optimal liver scan where we need to put our ROI. So deep inspiration is absolutely avoided. It's important that we have in suspended respiration. So what do we mean by suspended respiration? That means we ask the patient to expirate, and in that mid-expiration, we ask the patient to hold breath for just 4 to 5 seconds, and this also eliminates the motion artifacts. Once we have the suspended respiration, shear wave elastography is initiated, and we put this, of course, our Q box in the region that is most homogeneous. There are no large vessels, there is no hepatic nodule, and we find that it is how many? This is about 4 to 6 centimeters from the skin surface, or 2 to 3 centimeters from the liver capsule. It's very important that we adhere to the standardization of placing the Q box in the right position. Once this is done, the elastogram signal in the color box are judged, and we freeze the screen, scroll the trackball back and forth, and take the frame which has got the most homogeneous pattern, identify it, put 10 samples which are positioned in the color box, taking the central region as the region where it should be done. This will help you clear stare of these red regions, which are actually small bits of motion artifacts. So keep all the samples in the center. And of course, the probe pressure should be minimal, because as you put greater probe pressure, the liver elasticity seems to increase, even though minimally, but it's extremely important that we keep it optimal. And most important here is, of course, the alcohol abstinence. So once you're making an appointment, do make sure that the patient has not taken alcohol for at least 72 hours. So this is something which is very important at the time of making the booking, that you have to counsel the people who are giving the appointments to see to it that the patient is asked to abstain alcohol for at least 72 hours. Moving from here, the technique. So sorry, why is my screen frozen? Yes. It would not be fair to just keep talking about all the good points of shear wave elastography. There are some pitfalls as well. And those are that in acute hepatitis, we can have false positives. In patients with high body mass index, specifically, if the subcutaneous thickness is greater than 25 millimeters, there are erroneous values that can be obtained. And the confounding factors such as liver congestion falsely increases liver stiffness independent of the presence of fibrosis, because liver is encased, we all know, in a distensible yet non-elastic stiff glissons capsule, and this can cause significant variability which necessitates a review under optimal conditions. Then, of course, we need a postprandial status, which would, we need a nil orally patient or 4 hours fasting, because postprandial status raises stiffness and increases by virtue of increasing the blood flow. The interfering vessels, bile ducts, nodules, those are all very important parts. Putting your Q box less than 1.5 centimeters from the capsule or too deep, that means greater than 6 centimeters from the skin surface, would definitely lead to variability in the results. Rib shadows or narrow intercostal spaces again give us erroneous values, so it's important that you should avoid them. And one way to avoid this is keep the probe parallel in between the intercostal spaces. The edge of the Q box is extremely important, should be parallel to the liver capsule. It should not be at an angle. Increased probe pressure, as I just said, will increase unnecessary stiffness. So this is an important part, yet there can be a variability, and in order to minimize the downside of the variability of the data that we are taking, a statistical analytical model called as Interquartile Range was incorporated in most of the ultrasound machines, in nearly all the machines, and this comes as a post-acquisition tool. Now, interquartile range is a measure of statistical dispersion, as you can see in this graph here, where it's equal to the difference between the 75th percentile and the 25th percentile, and it actually eliminates the outliers. So we have a median, which is one of the values that we give for significant fibrosis or no fibrosis, but more importantly is that this median, of course, eliminates them. A more accurate one is the interquartile median ratio. And this interquartile median ratio has been incorporated because it gives a more indication of a more robust data if the value is less than 30%. So this is all in your post-acquisition tool. You don't have to do anything. It's a software that is there in your machine. All you have to do is pay attention to this ratio and put it down in your reporting format for the clinician to get the idea. So here we were talking about some of the tricks and tips, how you can have a great study. As you can see here, in the image, the left lobe of the liver cannot be used as the elastography box or study. Why? Because there's an insufficient thickness for putting the Q box. Also, the cardiac pulsations do interfere with a good quality of imaging. Putting your ROI or the box, Q box, should be at least 2 centimeters below the liver capsule, or at least 4 to 6 centimeters from the skin surface, which is very important because otherwise it interferes with the capsule, and this capsule in the subcapsular region or in the capsular region has got a high fibrosis content. Angle of insolation should be absolutely perpendicular to this Q box, and it's important that the upper edge of your Q box should be parallel to that of the capsule of the liver. Now, there are several factors that lower the confidence value despite a good technique of color map acquisition, which is like sometimes there are tissue areas which are, interfering with the vessels, as you can see right here, the vessel running across, or there is a low tissue echogenicity when there is ascites or the gallbladder is interfering. So do make sure that this interference is eliminated whilst you're taking your Q box into a particular zone. The shear wave strength can be reduced or weakened if your Q box is just too deep. It goes like almost beyond 6 centimeters. So 4 to 6 centimeters is important, and adhering to that optimal acquisition of the data. And large tissue motions, as you can see here, if there is going to be a respiratory and the patient is not going to be cooperative, you'll have all these artifacts, and then the data is going to be really erroneous. You can see the upper surface of this Q box, and you can see how it is angulated to the capsule of the liver. And well, this is not going to be really a good study here. Edge artifacts are very important, usually arise because of motion artifacts or the rib shadowings. So you, of course, need to reposition. We've already spoken about how the best way is to keep parallel to the intercostal spaces. And also, in addition, if there is an artifact, it's important that you take your samples in the center and clear steer off the edges of the Q box so that you have a great quality of the study. Now, this is a reference chart that has been taken from GE Healthcare documents for your take-home reference based on the most reproducible semi-quantitative system called Medveer score. And there are other scoring systems as well, like you have Buds, Ludwig, and you have a Shocks, but Medveer has stood the test of time. It's a 4-stage system where the liver stiffness measurements present a continuous range of values with some overlaps in Young's modulus that's given in kPa, and you have the values against which you have the fibrosis gate grading going from F1 to F4, and also the velocities which are given in meters per second. So here you can see that if it's less than 6.48 kPa, we are in F0 zone, but if it raises to greater than 9.31, then of course we are talking of cirrhosis and F4. So let me now just walk you through some case studies to elaborate on what we are saying here. Now, here was a lady who was diagnosed as NAFLD grade 1, and this patient showed a Medveer score of F0. Why? Because the kPa was 4.64 and the mean the velocity was less than 1.47, which was absolutely great. it was important for me to put this slide in because along with the elastography, what we are showing here also is a portal vein diameter to you, the entire color Doppler showing hepatopetal flows, velocities of the hepatic artery, velocities of the portal vein, splenic size, splenic hilum, splenic vein diameter, along with that there are no collaterals. So this just kind of raises the degree of confidence that we can give along with the elastography. It's entirely individual preference whether you would want to incorporate this or not. But this is how elastography works, shear wave elastography works wonders along with the ultrasound. F1 stage in a patient with mild to moderate fibrosis, you can see the elastic box, which is showing hues of nice, beautiful green, and a Young's modulus of 6.43 kPa, velocity of 1.47. And you can see here that the IQR median ratio was grade 30.5, which is kind of robust enough to say that we have an accurate data collection and there was not a significant variability here. Then again, F2, the IQR mean ratio stood at 24.2. And again, the KPA 6.85. Velocities here for you, giving us mild to moderate. F2 grading on a Met-Veer score. There were some edge artifacts, as you can see here, but we steered clear of them and took the data set in the center. And of course, we were also able to correlate it with the ultrasound findings to give a great reporting format. Then yet another asymptomatic patient. This was an obese type 2 diabetes, and there was grade 3 NAFLD, which was given on an ultrasound here. Liver stiffness was falling in a median of 8.33, as you can see here. There was velocity 1.64 to 1.76, still staying less than 1.76. Centrally placed, we had the all the data that we were taking here. The spleen size was borderline enlarged. So we took the elastography of the spleen as well, which was 9.12, we'll come to it later, which eliminated the presence of clinically significant portal hypertension. But this definitely fell in the range of compensated advanced chronic liver disease, even though the patient was kind of asymptomatic. So this gave us quite an insight into where we needed to go with this patient as far as the management was concerned. And then last but not the least, this is a lady with uncontrolled diabetes and dyslipidemic status with borderline deranged serum biomarkers. And there was severe fibrosis. As you can see, the KPA going through the roof, velocities greater than 1.76, and the data here was very robust. So you can see 15.1, and this was the EQR median ratio. And so we gave it F4, bordering cirrhosis. So all in all, instead of giving granular heterogeneous echo-pattern, fatty liver, we were really able to document where we stood with reference to fibrosis staging here. So it's quite clear here, okay, that the staging of the disease to glimpse into the future of the patient, to see how the disease is going to evolve, what are the complications that the patient may eventually land up with, is the big step towards what I believe that the clinicians actually want from a radiologist in order to proceed with the management. So the staging of chronic liver disease, detection of early fibrosis, which we know is reversible now, compensated advanced chronic liver disease, yes, we will be able to give an insight, and cirrhosis, absolutely. Prognostication of the complications of chronic liver disease, that means, is it going into a clinically significant portal hypertension? Are there presence of varices? The risk of bleeding that comes through splenic. The spleen elastography gives actually the insight into all these, the risk of bleeding or whether it needs, the varices need the treatment. And of course, last but not the least, the hepatocellular carcinoma, presence of it on an ultrasound. So I'm not really going to go with this. We will come back to it in the end so that we don't have to waste some time. I'm really going to come here into summarize the entire talk today. We must understand that F2 is significant fibrosis and F4 is cirrhosis with accompanying complications. Now, in between the two, lies what we call as the compensated advanced chronic liver disease, which we can confidently rule in or rule out. So here I'm very quickly going to go over without wasting much time. So these are the rule out cutoffs and rule in cutoffs. If it is less than 5.5 kPa and the velocity is less than 1.3 meters per second, we are really ruling out F2. If it is 1.3 to 1.7 and the Kp is greater than 6.78, we are ruling in F2, which is clinically significant. For cirrhosis, again, the rule out cutoff is if it's less than 8.41 kPa, we'll say no, we're really not into the cirrhosis stage, and the velocities are less than 1.7 meters per second. In the same manner, ruling in is if the Kp is greater than 9.15 kPa and the velocities stay in 1.7 to 2.1 meters per second. So in order to make this even more easy for you, here is this chart. Okay, so simple two values. What we are doing is less than 1.3 meters per second. We are here talking F0 or F1 stage, and which means that we do not really require additional follow-ups. And the next is greater than 2.1 meters per second, which require different management and prioritization of therapy. So between the two of them, we have a substantial overlap of F2 to F3. And this is when we would like to go back to that previous slide, the rule of 5, so that we can have likelihood ratios with a better tool for documenting the risk in this range. So this is a reporting standardization. We should always give the median value in kPa as well as velocity in meters per second on a Medfield scoring. The IQR median ratio is very important, should stay less than 30%. So minimal risk, we are talking F0, F1, no follow-up or 1 to 3 yearly follow-up. Moderate risk, F2 to F3, we have to do appropriate testing, keep them under observation. Maybe they are compensated advanced chronic liver diseases. So it is up to the clinician how frequently they want to follow this case up. High risk, of course, where we are F3, F4, and there is a 3-monthly follow-up. There is a risk stratification which can be given for the CSPH, EV, varices needing treatment, or the presence of hepatocellular carcinoma. Now, the one more important thing that cannot be, from a radiologist's point of view, overstated is that the patient position, the equipment that you're using, the manufacturer or your vendor, and the transducer frequency should be having a uniformity in your reporting format. And there should always be a mention how and when we have done it, so that every time we do it, how I do it is that where I actually put a mark and click an image so that when my patient comes again, I exactly know where to do the probe placement. With this, I come to the end of my presentation. Thank you supremely for your attention and your participation. Thank you, Aishwarya. You can take on from now.
Thank you so much, Dr. Nidhi. I would like to now invite Dr. Vivek Raj to be present for the presentation on a clinician's perspective for liver elastography. Thank you, sir.
You'll have to load my slides from your end.
No, thank you very much.
So tech team, could you please bring on Dr. Raj's presentation and we can continue?
It's going to be a difficult act to follow, Dr. Nidhi, for that excellent presentation, extremely instructive and wonderful. The job given to me was to see what is the clinician's perspective for fibroscan elastography. Next slide, please. So I think from a clinician's perspective, we are the end users. It's almost like what we use in computers. I equate that I use the PowerPoint, I use the Word. I don't understand too much of what goes into it, but I end up using it effectively and then trying to see what information. So radiologists are our eyes inside the abdomen. They are the peel inside the abdomen for us. So it's a very important thing for us to work very closely with the radiologists. And we are very thankful for all the help and assistance and information and details that they give us. So assessment of liver fibrosis, why is it important? I think Dr. Nidhi has already outlined very elegantly why it is important. The main thing I want to emphasize is that if we know whether the patient has early fibrosis or late fibrosis or whatever the stage of fibrosis, it is important because fibrosis is a slowly progressive process and it gives us a window of opportunity. So we don't go from zero fibrosis to cirrhosis in a matter of 3 months or 6 months. It takes, depending on the disease etiology, it may take 4 years, 5 years, 20 years, whatever it might be. So that gives us a huge opportunity to treat the underlying condition, to change patient behavior, as the case may be, whether it is alcoholism, whether it is non-alcoholic fatty liver disease. So it gives us a huge window of opportunity to intervene effectively to decrease the progression to cirrhosis, which otherwise is a disease which has a very high morbidity and mortality once we reach that stage. So there are many methods of assessing cirrhosis or fibrosis or advanced cirrhosis, advanced chronic liver disease, and they all have to be taken into conjunction. So the invasive techniques obviously are liver biopsy, laparoscopy, measuring the hepatovenous pressure gradient, and endoscopy to look for portal hypertension changes. And the imaging studies, non-invasive techniques are imaging techniques, liver stiffness, then blood markers. And I'll talk a little bit about the blood markers also as we go along. Next slide, please. I think this has been again covered a lot by Dr. Dhar and Dr. Nidhi. So why do we bother about measuring fibrosis? So hepatic fibrosis occurs in response to chronic liver injury from any etiology, whether it is alcohol or hepatitis C or hepatitis B or fatty liver disease. This hepatocyte injury eventually results in collapse of hepatic lobules, formation of fibrous septa, hepatocyte regeneration, nodule formation, and cirrhosis. And it then finally results in all the complications that we see with cirrhosis: portal hypertension, impaired hepatic function, low albumin, ascites, encephalopathy, immune response. So if we can arrest this cascade, then we can probably at least prevent further progression or maybe even reverse the fibrosis. Next slide, please. So why do we look at non-invasive markers of fibrosis? So initially hepatic fibrosis was thought to be irreversible, but now we recognize that it is a dynamic process with, if not complete, but at least some significant degree of reversibility. And that reversibility component is the holy grail that we have been looking for ages, to see how we can reverse the fibrosis. And now it's been demonstrated in hepatitis C treatment, in fatty liver disease treatment, and even in some cases of alcoholic chronic liver disease. Once the patient has quit alcohol, over a period of time, we can demonstrate some degree of reversal of fibrosis as well. Liver biopsy has remained the gold standard for assessing fibrosis and cirrhosis, but it has major limitations, as outlined earlier by Dr. Nidhi also. It is an invasive procedure. It has complications, including mortality. So liver biopsy carries a mortality of anywhere from 0.1 to 0.5%. And once you have done a liver biopsy and the patient dies, it's extremely difficult to explain to the patient, the family, and medico-legally. So that's why the overall use of liver biopsy has gone down, as we have got more and more better markers to study without doing a liver biopsy. It is expensive. It cannot be repeated often, so you can't do it every year, every 2 years. It samples only a tiny part of the liver, so there is a sampling error, as Dr. Nidhi pointed out. Only 1/50,000th part of the liver can be sampled, only from a particular peripheral part of the liver. So you may be missing a lot of the pathology that is actually variably affecting the liver. There is a significant inter-observer and intra-observer variation when we start doing a liver biopsy, assessing a liver biopsy, reporting on a liver biopsy. So that makes errors creep in. When we look at non-invasive assessment of hepatic fibrosis, either biochemical or ultrasound-based assessment, the advantages are that it is cheaper, it has no complications, it can be repeated easily, so we can follow the disease course non-invasively. So we can do it every year to assess progression or regression of the disease. We can assess it as a screening tool in patients, so we can detect the disease early. It samples a larger part of the liver, so it decreases the sampling variation. We cannot assess every part of the liver even on these parameters, but however it does that. There is less inter-observer variation, and it is a quantifiable technique. So unlike a fatty liver assessment on visuals by the ultrasonographer, mild, moderate, severe, or grade 1, grade 2, grade 3. This gives us a quantifiable number, which is also important from patient care perspective, because when we tell a patient who has come in, for example, with non-alcoholic fatty liver disease, that your CAP values are 400, 350, and your the stiffness is say 8 or 10 kPa, and that if you do the right things, we may be able to see improvement in these parameters. And he comes back 6 months later, and with adequate effort and adequate treatment, these values have come down. It's very encouraging for the patient then to continue on those lines. Similarly, if the condition is worsening, which he hasn't taken adequate care, and he sees the numbers going up, it's very easy to then convince him to actually do the right thing in order to improve his clinical status and his disease progression, or to arrest the disease progression. So the quantifiability is a very important, useful parameter when we come to clinical practice in dealing with patients. Next slide, please. So this is a Metavary score that Dr. Nidhi had alluded to. So this is assessed as no fibrosis, which is F0, portal fibrosis without septa, which is F1, portal fibrosis with a few septa, which is F2, portal fibrosis with numerous septa but without full-blown cirrhosis, F3, and cirrhosis with nodule formation, everything else is F4. In addition, Metavare activity score is also there, which suggests the degree of inflammation, mild activity, A0 is no activity, mild activity, moderate activity, and severe activity. Now, any of these ultrasonographic or fibroscan methods assess the fibrosis score. They don't give us a activity score. For that, liver biopsy is essential. Next slide, please. So this is just a histological assessment, and I think Dr. Dhar also showed some of that. So the first slide on the left is basically showing you just a normal liver in a high power, and then we go on to advancing fibrosis. There's portal tract inflammation and portal tract expansion. Then there is development of fibrous septa in the portal tract or around the portal tracts, and then bridging fibrosis that is happening between the portal and central vein, and then finally lobule formation or cirrhosis. So a lot of the studies that have been done to assess non-invasive markers have been correlated primarily with the histology to see how accurate they are. Next slide, please. This is what we commonly use as a fibroscan, and different diseases have slightly different cutoffs to a certain extent, but overall there is some degree of variation. So at the lower end of the spectrum, anything below 7 kPa is considered no fibrosis, which is F0 to F1. Anything more than 12 is a rough number I would like you to remember, means there's advanced fibrosis or even cirrhosis. Now this varies from disease to disease. So in hepatitis B, typically advanced fibrosis or cirrhosis, so F3 is 8 to 11, while F4 is 18 or above. Hepatitis C, 14 or above is cirrhosis. Hepatitis HIV co-infection, again 14. In cholestatic disease, 17, and non-alcoholic fatty disease, 14. So the good numbers to remember are 2, 12, and 14, because that will easily make you remember whether you are in a clean or rather safe level, or whether you are at advanced cirrhosis level, and everything in between will be F2 or F3 fibrosis. And anything more than F2 fibrosis, as Dr. Nidhi pointed out, is significant fibrosis with a high rate of progression to further chronic liver disease, and the intervention becomes increasingly imperative at that stage. Next slide, please. This was a large study. I have just brought in some studies in this. This was a large study of 450 patients with suspicion for non-alcoholic fatty liver disease, who all were prospectively recruited, and a liver biopsy was done in all patients, and a fibroscan was done in all patients. So within 2 weeks of fibroscan, the patient had undergone a liver biopsy. And if you look at the receiver operator curves, you see that the CAP for steatosis had a high area under the curve. So did the assessment of advanced fibrosis, and so did the liver stiffness measurement for cirrhosis, which basically tells us that CAP levels and liver stiffness measurement with fibroscan are reliable biomarkers for non-invasively assessing the liver steatosis and fibrosis in patients with non-alcoholic fatty liver disease. So it is with these sort of data that we started getting more and more confident about using fibroscan and other non-invasive markers for assessing fibrosis and cirrhosis. Next slide, please. And for those of us with gray hair, we realize what we used to do and what we are doing now in terms of liver biopsy. So over the years, the use of liver biopsy has dropped down significantly. So when I was a fellow, practically every second or third day, we would have about 8 or 10 patients lined up for liver biopsy, and we'll go boom, 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 biopsies and out. And that is the time when a lot of the initial research was happening on hepatitis C, on hepatitis B, and non-alcoholic fatty liver disease. The only way to know whether the patient has disease or not, or what is the extent of disease or severity, was liver biopsy. As time progressed, the need for liver biopsy has progressively come down, and it is being used less and less. So one of the early things that happened was hepatitis B DNA levels as tests came out, hepatitis C PCRs came out, and effective treatments for hepatitis B and C started coming out. Then there were more precise PCR tests that came out. As a result, we were using more of those markers for deciding treatment and assessing response to treatment than liver biopsies. And then in the late 2000s and early 2000, soon after 2005, 2007 is when FibroScan and non-invasive blood test markers came out. And progressively the need for liver biopsy has decreased. There still remains a place for liver biopsy in patients where we are unclear about the diagnosis. In patients where we have to definitely quantify the extent of liver damage, for example, pre-liver transplant. In patients where there is a variability in the liver parenchyma at different levels, and we got to assess what's happening in, say, left lobe versus right lobe. So there will always be a place for liver biopsy, or for diagnosing tumors, for example. But I think overall, for the general assessment of liver disease, the role of liver biopsy has come down significantly. Next slide, please. So these are the non-invasive serum markers, and the reason it's important to know this because not everybody around the country will have ready access to FibroScan or to elastography or to high-end radiologists like we have in Delhi, for example. These are markers which can be very easily used on the bedside. It takes into account, for example, PIP4 score, which is very commonly used. Basically, the components are platelets, AST, ALT, and age. And these are all now easily available on your cell phone or your computer or whatever. You can just fill in PIP4 and they will give you a calculator. You can easily use that as a calculator to get your cutoffs and get a good idea. And this is about 70% accurate, roughly, or 70% sensitive. Most of these scores, there's some variabilities among each one of them. Then there's the APRI score, which takes into account only the platelets and AST. Fibro test, which is now being offered by many of the labs like Lal Labs. These are commercial panels, which also measures alpha-2 macroglobulin, GGT, bilirubin, and takes multiple factors into account. And this is a commercial panel, which then gives you a number again, along with assessment to say whether it is correlating with no fibrosis, early fibrosis, or late fibrosis. ELF score, NAFLD fibrosis score, which is specific for fatty liver disease patients, again taking into account very simple parameters like platelets, AST, BMI, and albumin levels. Formula is complex, but calculated by a computer now, so it's very easy to use as well. So without going into details, the main idea is that you should know that these scores exist, that in your patients on the bedside, on the clinic, you can easily use these, and you can again repeat them very easily 6 months down the line or year down the line to see if there's progression of disease, if there's regression of disease. Next slide, please. So this is Dr. Nidhi already made the job easier for me. So there are different radiological or methods that we use for assessing fibrosis. FibroScan, which is for vibration controlled transient elastography. It is easy to do, has a good reproducibility and low inter-observer variation. Less than 7 kPa are normal, more than 12 to 14 kPa consistent with cirrhosis in general. High sensitivity, high specificity. 2D shear wave elastography, which Dr. Nidhi has discussed in great detail, which has a high sensitivity, high specificity, and obviously the advantages are that the radiologist is doing it. So most of the time the fibroscans are being done by technicians who have been trained to do it, while most of the ultrasound guided shear wave elastography is being done by radiologists. So you get a lot of additional information, and you can then, besides just the stiffness measurements, as Dr. Nidhi pointed out, and obviously the usefulness is much more when you're talking to a physician. So there are pluses and minuses for each of these. We'll go about that in a minute. MR elastography, which is highly accurate, very reproducible, but has an issue of cost associated with that, and the availability of MR is not as widespread. Next slide, please. So this is non-alcoholic fatty liver disease, what we very commonly use for FibroScan. And the two things as a hepatologist or as a gastroenterologist I'm interested in is finding out what is the liver stiffness, so that can give me an idea of hepatic fibrosis, and controlled attenuation parameter, which to a certain extent gives me an idea about hepatic steatosis. So those are two factors that clinically we use very often. Next slide, please. So where do we use these in real life? We use it for assessing fibrosis at initial diagnosis in a variety of chronic liver diseases, from chronic hepatitis B, C, NASH, or alcoholic liver disease. So that tells us where does the patient stand when we first see the patient, or even as a screening tool in patients, for example, who have hyperlipidemia, diabetes, metabolic syndrome, may or may not have fatty liver disease or ultrasound. We would use this as a screening tool. We also use it to separate out patients with no or minimal fibrosis from significant fibrosis and cirrhosis, because again that helps us decide what treatment to start, how emphatically do we need to tell the patient what they need to do. So even if the patient thinks that he's a moderate drinker but has on FibroScan, for example, is suggestive that it is F2 to F3 fibrosis, we would strongly advise him to give up alcohol completely. Lifestyle modifications in terms of weight loss, in terms of diet, in terms of sugar control, in terms of hyperlipidemia control, all these things become very important once we have a patient who is already as F2, F3 level or has F4 or cirrhosis. So I think that is where we need this non-invasive markers to help us guide the patients better. In certain situations, for example, in hepatitis B, many times the patient's DNA levels may be low when they have reached advanced fibrosis or early cirrhosis stage. The DNA levels fall. So if you are using DNA only as a parameter or using just ALT levels as a parameter, those will be misleading at that time. On the other hand, if the FibroScan gives us additional information that the patient has advanced fibrosis, then these patients will need to be treated, and they will need to be treated for life practically with some of the oral drugs that are now easily available. So it does help us in identifying patients who need treatment in chronic hepatitis situations as well. Also, assessment of response to treatment or progression or regression of disease, which we already talked about in a longitudinal and quantifiable manner. And this can be used as a motivational tool for the patient, as showing the mirror to the patient to say what they are doing is right or they are doing is wrong. And also clinically it tells us when to intervene further, when to start, say, endoscopic screening in patients who may require, who may have varices, when to start screening for hepatocellular cancer, portal hypertension status. So multiple factors that actually come into play at this level. As this is the last part of this slide, is assessment of need for HCC screening. So patients who have advanced fibrosis should go into a HCC screening protocol on a regular basis, on a 6 monthly to a yearly interval. Next slide, please. So there are many determinants of liver stiffness, and we have to be aware of those because that may cause sometimes false readings, and we have to be aware about the limitations of that. So inflammation from causes such as acute or chronic liver failure, acute hepatitis, acute and chronic hepatitis, active alcohol drinking, chronic viral hepatitis will give us slightly skewed levels of stiffness. So we have to take that into account. The blood volume and liver perfusion, which Dr. Nidhi already alluded to, fatty infiltration, the amount of fat infiltration, cholestasis. This is something we very commonly see as an artifact because many of our inpatients who have, say, sepsis-associated cholestasis, who have TPN-associated cholestasis, and we are trying to assess if they have cirrhosis or not, cholestasis can actually give us false readings. So one has to be aware of that. Similarly, with heart failure, where the patient may have a high central venous pressure, or the patient has just eaten. So I think Dr. Nidhi has already alluded to that in great detail. Next slide, please. Next slide, please. Yeah. So what are the advantages and limitations of FibroScan, which is a technique that a lot of the gastroenterologists are more used to because it's more easily available on the bedside, and we can get the machine in the endoscopy suite or in the outpatients, and mostly it is done by a trained technician, so we get the report faster. So there are many advantages. So it's high reproducibility. There's a good inter and intra-observer agreement, good positive and negative predictive value at both ends of the spectrum, which is what we are interested in. It has a good correlation with prediction of complications. CAP values help us in assessing the fat content. What are the limitations of FibroScan? It is not accurate in obese patients. It is not possible to do it in patients with ascites. It needs a good acoustic window, and sometimes it is difficult to find, especially in slightly obese patients or patients with some respiratory problems. Sometimes you can't find a good intercostal acoustic window. If there are variations in the two lobes of the liver, then again you may get false readings. Any space-occupying lesion interferes with it. Conditions like focal nodular hyperplasia again can give you false readings. For diagnosing significant fibrosis, sensitivity is 70%, specificity is 84%. It is definitely better for cirrhosis, where sensitivity is 87%, specificity is 91%. So at both ends of the spectrum, the sensitivity and specificity is very good. In the middle of the spectrum, the sensitivity drops down a little bit. So those are the limitations. Next slide. So point shear wave or 2D wave elastography, I think Dr. Nidhi has talked in great detail about it. And as an outsider through radiology, my knowledge about this is relatively limited. So what the advantages it offers is it can be done at the same time as ultrasound using the same machine. It can be done in the presence of ascites, minimal ascites at least, and I think my Dr. Nidhi can correct me in how much ascites should be there before you can say, no, we cannot do it. Obese patients still pose a challenge even in this. There's 2D is more accurate than point shear wave elastography in predicting fibrosis. The limitations are it is to a certain extent operator dependent, so you need to have a well-trained radiologist who's doing it, needs to spend time doing it. Necroinflammatory activity can cause overestimation. The quantification of fat content, at least to my knowledge, was not possible, but I had just been corrected with Nidhi that now with the newer techniques and the 2D techniques, you can actually do a CAP value assessment and fat content assessment as well. The inter-observer and intra-observer variability exists. The range in terms of velocity is relatively narrow, so sometimes makes it difficult to assess the improvement or regression or progression of fibrosis. Next slide, please. So I think there's some questions I was seeing earlier on the question panel also, which is better. So my answer to that is for forms of government, let pools contest. The government that best governs is the best. So whether we use FibroScan or RF-based measurements or 2D elastography, we need to know what we are looking at, what are the advantages and disadvantages of it. And there will be, the whole idea is not to get the best data possible at all times, but use the data in the right patients for the right reasons. And if you have a good ultrasonographer available or not, whether you are getting a person or a technician to do your FibroScan or not. So there are many factors that will come into play in applying these to real practice. But the main important thing is that what is the utility of each of these methods? And I think in the discussion, we can probably have better perspective from our radiology colleagues about the benefits and disadvantages and advantages of each one of them in terms of the technique. There are many factors that come into play: marketing, financial reasons, turf issues, hospital support, what equipment they want to buy. So there are all these factors that come into play. But as a physician, we need to relegate them to the sidelines and focus on the academic and patient care issues. So that's why I said whether we use, if we don't have elastography available and we don't have FibroScan available, use the blood markers for taking care of your patients. If you have any of these facilities available, use them at the right indications, not for commercial reasons, but where it is indicated for the patient, use them appropriately. If you have a good ultrasonographer available who can actually help you with all this information, then use the services of the ultrasonographer and have a constant communication with the radiologist so that you can actually come up with good information and use it effectively for your patients. Next slide. So this is the question for the audience. Can elastography be done in case of ascites? Simple answer, yes or no. I think we'll go for the poll.
Thank you, Dr. Raj. The tech team, please relay the poll to the audience for the audience to answer. All of you have a minute to answer, please. So thank you, Dr. Raj. It was good to hear from you in terms of FibroScan versus liver elastography. Following on, we'll have Dr. Chander Lulla to provide a radiologist's canvas on liver elastography. Due to paucity of time, I would be asking, we'll have Dr. Chander Lulla on, followed by the panel discussion. We will do the video post the panel discussion, just to ensure that we cover the most important aspects. Tech team, do we have the results?
Right. So that's interesting. I think we should discuss this in the panel.
Absolutely.
Yeah. So
That's a very interesting, poll.
Yeah.
We must. Right.
So I think I'll leave it for the panel discussion to actually go over this.
We will. And Dr. Raj, that was a fantastic presentation. I'm sure it has raised a lot of questions. So you be ready for some really strong questions coming your way.
Sure.
Over to you, Dr. Lulla. Thank you so much.
Thank you, Nidhi. First of all, I'm extremely honored to be following stalwarts like Dr. Raj, Nidhi, Dr. Dhar. I think it was very enlightening even for me. And I'm going to share what we have been doing since the last 10 years with elastography. We started in the year 2010. I just share my screen. So I'm going to talk on the radiologist's perspective, as Dr. Previously spoke on the clinical perspectives. So from the radiologist's perspectives, we need a one-stop clinical assessment of risk, as we use in obstetrics called OSCR. We call it a one-step assessment, where we do ultrasound, color Doppler, shear wave assessment. And then I'm going to touch a little bit, as has already been spoken to by Dr. Raj, on 2D versus FibroScan and how do we use quality factors. At the end of the day, we want good results. We just don't want a figure to be given to a patient which is arbitrary. We need to be ourselves convinced that we are giving a good quality value. And then, as he also alluded, we now have liver fat estimation with ultrasound called UGAP, ultrasound guided attenuation parameter, which is similar to this CAP steatosis staging. So as radiologists, we have always been doing anatomical and physiological imaging with vascular flow, but we have added since 2010 to our armamentarium of evaluating mechanical stiffness of various tissues. So it's not only limited to the liver. Of course, this is limited to the liver. We also now have various guidelines, and there is the SRU guidelines, the FSM guidelines. So things have been well accepted, and we move on from them. The goals of the various guidelines are to understand the variability of elastography measurements, intrinsic and patient factors, and all that has been already alluded to in the previous talks. I'm not going to get into that. Review factors that affect measurements, again alluded to, provide guidance on how to perform the examinations, and Nidhi has done a wonderful job in interpreting the results and reporting the findings, and determine where ultrasound elastography can be best used in clinical practice. Dr. Rajiv has already given it in the previous talk, and of course for further results. Now, just to go historically into what elastography is from the point of view of radiologists, it started way back, probably even before 2000, as strain imaging, where we could differentiate stiff from soft structures just by putting the transducer, pressing the transducer, and creating an elastography map. And then we started in 2010 getting 2D shear wave and point shear wave. And finally, in 2014, we had 2D shear wave, which allowed us in a single shot to get information not only of the 2D picture with the shear wave, and also get multiple measurements as the image kept upgrading. And that's when we started getting interested in shear wave elastography. And these are the various toxins which have already been alluded to. There's a whole list of them. And we follow through the stages of fibrosis to cirrhosis and ultimately to hepatocellular carcinoma, as you can see in this cartoon. And what has really been a great boon to us is that this is potentially reversible. And when anything is reversible, we need to monitor it over a period of time, as has been alluded to again. And basically, we are interested in this subgroup of compensated cirrhosis where clinical diagnosis is not easy. And we need to follow and evaluate these patients and keep them on a close follow-up vis-a-vis a decompensated cirrhosis, which is an easy clinical diagnosis. So here, you may have a smaller risk of mortality if we don't know what's happening, and that's where we really come into. Nidhi has already spoken about the various gradations that we see on histopathology. We have Ishak, Metavir, and BAT scoring, and these are some of the cartoons which give us a better idea of what these scores are like. But what's interesting is, as we saw in the previous talk, we had the liver fibrosis Metavir scoring from F1 to F4, the necro activity which is seen on biopsy, and now what we are seeing new with ultrasound is actual gradation of steatosis from grade S to grade S3. And we are no longer talking about whether liver looks brighter than the portal vein or less brighter than the portal vein or the surrounding kidney or the diaphragm. We are actually telling you this is stage S, S1, S2, S3, depending on the attenuation parameter of ultrasound. And this indirectly tells us what is the fat content of liver. So, as you know, the epidemiology, you just saw that alcohol was one of the bigger problems that was alluded to in the first talk, but we have 40 to 50 million carriers of hepatitis B in our country, about 12 million carriers of hepatitis C, and of course, this is 3% of the world's population, and of course, these figures can be questioned and they can be corrected if I'm wrong. But we've had biopsy, as the previous speaker just said, that liver biopsy, they were doing 8 to 10, just like we do kidney biopsies today, and probably in the future we'll be doing fibroscan even for the kidney. And then serology and imaging is really the cornerstone. So there is a great need of the hour to have a non-invasive marker, which is quick, which is does not involve any radiation, not going into any complex machines like MRI, and it's integrated into the ultrasound platform for a one-stop clinical assessment of risk, and it gives immediate results. You don't require extremely high trained personnel, and there are no measurement failures in obesity and ascites, and at least at a depth of 10 centimeters we can image. So if you've got ascites of less than 10 centimeters, we can image the liver. So ultrasound has been excellent for looking at liver disease. You can get a lot of parameters. I'm not going to go into all this. These are very well established parameters, and that's why it's good to have a third parameter. So you have anatomy, you have blood flow studies, and all of this gives us information. As you can see here, there is reversal of flow in the portal vein, so severe portal hypertension, and this all tells us that what is the exact status of the liver, along with, of course, now fibroscan and UGAP. So, as again alluded, liver biopsy, a lot of disadvantages. I'm not going to go into it. But the imaging point of view, from radiologist point of view, we have a lot of techniques. We have MRI and we have ultrasound, as has also been alluded to. A little bit about transient elastography, because I'm supposed to give a radiologist's perspective. I will have to tell you the correct perspective, what is done with transient elastography. It's a push pulse technology, a vibrational technology, which is a blind technology. You have a pencil probe here, something similar to an amplitude mode examination or an A mode examination, which we used to use in ophthalmology. And they just pass a vibrationary pulse, and this gives us a value in terms of kilopascals. It's a blind technique. It does not give us any ultrasound information, no Doppler, and the Oscar concept is not possible. So these are some of the images that you get in transient elastography. Of course, very useful values, but they are subject to how the technique is effectively done and what are the fallouts. Now, a lot of comparison studies have been done between the various techniques. Of course, MR is excellent, but as has been previously spoken, it is expensive. You need to go into a machine, and it's not a screening tool. We have transient elastography, point shear wave, and 2D shear wave elastography, all pretty similar. Transient elastography, as correctly said, is point of care. So you need to do it quickly in the endoscopy lab, you use it. But if you're doing an elaborate study and you want to do a proper study, then of course you need to rely on ultrasound and 2D shear wave. Transient elastography is also more expensive. You need to remember that the probe needs calibration and recalibration every 6 to 2 months. There are failures with obesity and ascites. No grayscale imaging is possible. And some studies suggest that the performance is lower compared to shear wave ultrasound. So just to give you a clear understanding, this is what ultrasound can provide. You can rule in the presence of mass lesions, both with strain elastography and point 2D shear wave, shear wave elastography, which would not be possible. And you know that some of these patients, at least 2 to 3% of them, would have these mass lesions. And this would give us erroneous results if you're just doing it as a screening test, and you may get false positives. Very similarly is another patient here with a very, very small liver, and he's got an extrahepatic portal hypertension. Our shear wave velocities were normal, the biopsy was normal, and this would create a little bit of a problem with the very small sized liver, and you can clearly see the diagnosis on ultrasound as an extrahepatic portal hypertension. Follow-up studies are very easy to do with ultrasound-guided techniques. So this was the patient with hepatitis C positive. Biopsy 3 years ago had shown cirrhosis. She was on rabivortin treatment, and now the shear wave velocity is down to 1.7 meters per second. Another patient, autoimmune hepatitis, past biopsy had shown severe fibrosis, normal LFTs, and you can well appreciate the appearance of the liver with altered architecture, and now the value is 1.57 meters per second. We spoke about fatty liver and lifestyle disorders. These are actually two brothers who come for regular screening. One has, both have ethanol abuse and diabetes. One has stopped, and you can see his values are low, and the other one is continuing 1.69. So as the previous speaker alluded, once you give a value to the patient in comparison here, they are quite responsive to this kind of information. Of course, if you've got acute hepatitis here, as you see here, with the gallbladder is thick walled, the liver is enlarged, and you may get false positive values. Now, what's most important is look at the number of vessels here, and you need to select an area from where you are actually taking your value. And you see this liver looking otherwise all right, just looks a bit of fatty, but your values are very high, 3.75 meters per second. And you also got some kind of mass lesion here. So this is very, very important that if you're going to do a transient elastography, how are you ever going to avoid these vessels, and how are you going to avoid these lesions? So it's kind of a futile exercise for me to do a test which is riddled with uncertainties and which is a blind technique. So when we started in 2010, we did about 100 biopsies and we established our own values, and very similar to what you see today in published literature. So I'm not going to go into that. Now, we started with RFE, that is point shear wave, and today we have 2D shear wave elastography, which is multi-dimensional. It gives us values both in MS and KPA, and it also allows color differentiation. So in the box, if you see color differentiation, immediately you know you're dealing with no fibrosis, a little bit of fibrosis, and when you have multiple scatter red spots, you know that this liver is extremely inhomogeneous. So something which is not easily appreciable to the eye is quickly caught on when you're doing shear wave elastography, and that's really an important advantage. So it's image guided. You can avoid vessels, you can avoid imaging near the liver capsule, avoid focal liver lesions, and can be used with obesity and ascites, and that's really the important thing. There have been comparative studies of RFE and T, and pretty similar sensitivity and specificity in well-controlled studies. But if you see the area under the curve, in most articles, RFE is scoring over, especially if you're dealing with moderate fibrosis. And I think we heard in the previous talk that in extremes, transit elastography is good, but when you're dealing with mild to moderate fibrosis, where you really want to see for long-term follow-up, then RFE is scoring a little bit over there. Location specific, probably segment 7 and 8 has shown to be the best results. So that also can be selected on the 2D shear wave, and also you can use it with high BMI, any sex and any age issue. Now, we usually do a stepwise approach. As Nidhi has already said, we take a proper history, although it's always provided to us. Sometimes pathology studies are there, but we do ultrasound and color Doppler. And what's really important is the quality assessment. And that's the core of my talk, is that we can select the areas from where to do the imaging, and we then, even shear wave can have deterioration or attenuation as it passes through the liver. So you have to have some kind of quality check to see whether you are correctly placing the ROI and whether it is possible. So this is a quality assessment. Now, what we do is we do a split image assessment after doing a regular ultrasound, and I think Nidhi also spoke about this. This is the quality assessment bar here, and if it's homogeneously yellow, we know we can rely on the shear wave quality, and only then do we take the shear wave measurements in this measurement area here. So, and then we place the cursor. You can see that it's yellow here and it comes up as green here, telling us that you can now go ahead and take the shear wave velocity. Now, if you've got a vessel, for example, it will highlight as red, and you know that shear wave quality is not good, or this could be a cyst or very similar structure. And immediately your cursor, your ROI will turn red, as you can see here, and which tells you that you should not take this measurement. So there are a lot of selection protocols which with this quality control graph is provided. And then again, we take the median value, and I'll just spend a moment on this, because although Nidhi spoke about the interquartile range, we don't take the mean value. So we don't take an average and add and divide by the number of values. We take the center point, and that's why the IQR is very, very important. It has to be not less than 30%, not more than 30% of the value, so that your median is reliable. So that is something we always take. We take the median value, and then we report. How many measurements? If your IQR ratio is less than 0.30 and your quality control is good, you have got a good shear wave, as low as 5 measurements are enough. You don't need to go more than 5 measurements. And this, you can also take pictures of the quality control bar, and this helps us to monitor the sonographer quality, and we can make them improve with experience. So we also use a lot of graphic display when we give the reports in terms of where exactly the patient stands. And this is very, very important, because patients understand numbers and they understand graphics, and it plays on them to know where do they stand. Now, Nidhi already spoke about the SRU guidelines, and again, this is a good graphic for the radiologists to remember. We increase every level with a level of 4, so 5, 9, 13, and 17 kPa, and similarly 1.3, 1.7, 2.3, and 2.4, 2.1 and 2.4, and this allows us to remember easily that anything less than 9 kPa, in the absence of clinical signs, we're ruling out chronic active compensated chronic liver disease. And 9 to 13, it suggests but needs further tests. More than 13, we rule in. More than 17, we are talking of cirrhosis and portal hypertension. And she already spoke, and we just interplay both these graphs together for easy understanding for the radiologist. Now, this is the new thing that we we have started doing since the last 3 months, and that is assessment of NAFLD. And this is on the Logic E10. We are using the U-gap, which is the ultrasound guide, very similar to what the CAP technique is on the FibroScan. We can actually quantify the liver fat estimation. And so, as you know, NAFLD is prevalence in about 25% of the general population, and I think it's going to overtake alcohol very soon because of obesity, type 2 diabetes, hypertension, and dyslipidemia. And we know that till now we were looking at fibrosis, and we have now the opportunity of looking at steatosis, which is before the stage of NASH and before the stage of fibrosis. So we can prevent this 10 to 20% progression to NASH, 25 to 50% progression to fibrosis. So this is really exciting, because just by lifestyle modification, we can improve patients to not go into a stage of NASH. And also we know that there is an association between quantity of liver fat and the risk of cardiovascular disease is already known. And again, very similar to fibrosis, which has long-term changes. It takes time to change. Steatosis is a very, very dynamic process. And I may be given more information by the clinicians on this panel. It is said that the changes in steatosis can occur in weeks. And if you have a lifestyle modification. And ultrasound, which Nidhi spoke about earlier, is only 60 to 65% accurate for correct staging of the fat content of the liver. So it's a very observer-oriented modality, grade 1, grade 2, grade 3 fatty liver. And I see that in a very short span of time, we will be talking of SO, S1, S2, S3. So this is a real-time ultrasound image. It's got all the advantages of shear wave imaging, so I'm not going to go into that. The technique is very similar. We select 7 and 8, and in the supine position, intercostal, with the arm elevated, 4 hours of fasting. And again, very similar, we have quality control measures here. So we have a color map, and this is a color quality map which tells us we can rely on the attenuation map here. If it's homogeneously blue or red, we can choose the color. And then we have a color attenuation map, just like 2D shear wave, which tells us what is the fat content of the liver. And we can go up to about 8 centimeters. So essentially we may go from 4 to 8 centimeters, and we give the measurements either in attenuation rate, that is the decibels per minute, or decibels per centimeter per megahertz. So usually we use this attenuation coefficient. And again, if your cursor turns red, we know that we should not rely on the data, and we need to reject those frames. So the method is very similar, and if at the end you would like to see the video after the panel discussion, we have taken about 3 to 4 cases, and how to do it is what we have shown. So the do's and don'ts are again very similar to 2D shear wave imaging. So essentially it's the same machine. We start with UGAP, we do the fat estimation, and then we do shear wave evaluation. And you heard in the previous talk that if there's very high quality content of fat, then your shear wave velocities may just be a little warped. Now I've made a little cartoon for easy understanding. So SO is less than 5% fat in the hepatocytes. S1 is 5 to 33%, and the attenuation coefficient is 0.53. S2 is 33 to 66%, and the attenuation coefficient is 0.6. S3 is more than 67% fat in the hepatocytes and 0.66. And this is the scatter plot. And this was based on the Brunt grading, and I'm sure the clinicians would like to tell us more about this. And it is very similar to what CAP has been doing on the FibroScan technique, except that, again, we have the advantage of 2D imaging, color Doppler imaging, and we know where to put the ROI so that we can avoid the vessels, avoid the tumors, can avoid being close to the liver. And you can see here, this is severe fatty liver disease, which shows a color attenuation like this. If it's homogeneously blue, that's a normal liver, and moderate fat. But we also have values to this. So the values are, as I told you earlier, in decibels per centimeter per megahertz. The accuracy is very high. It compares favorably to the performance of CAP, especially if it's S2 or higher. It's also UGAP also has a high accuracy in detecting hepatic steatosis in patients with chronic liver disease. The area under the curve is more than 0.9, and you can see that there are already various studies which are telling us that. And you can see that this is again S1 more than 0.53, S2 more than 0.6, S3 more than 0.65. So this is again a comparison with CAP and pretty similar results, and also with MRI. So here you can see the limitation of CAP is insufficient visual guidance, as it can be performed in only A mode. Again, the same limitation of transient elastography, which ultrasound guided fat estimation is scoring over. And similarly, with MRI, of course, there is good correlation, but MRI has its own limitations of availability and the problem of the patient going into the machine. So let's quickly look at 3 or 4 cases till we see the video later. Now, this was a case, 50-year-old on ethanol. His shear wave was 1.63, suggesting F2 to F3, but his UGAP was very high. So you can see the liver looks quite bright. That's a shear wave image that we are doing. You can see that the shear wave quality is yellow, the ROI is yellow, so we can rely on the map, and that is the UGAP. Again, all the ROIs are yellow, suggesting that we can rely. And this is the measurements that you get. The IQR is 3%. And the IQR is 9%, so pretty homogeneous, and that is because we are already pre-selecting. We are selecting the best area, we are avoiding blood vessels, avoiding any lesion, and the quality control of the shear wave in itself, because shear wave, it cannot be homogeneous at all the times. It depends on the skin obesity of the patient. There's going to be attenuation of the shear wave as it goes through the skin of the patient if it's got a high BMI, and only if the shear wave quality is good, you can achieve an IQR as low as sometimes 3% and 9%. Now, this was case 2, diabetes on glycophage. He was also on statins. Cholesterol was high, and so were the LFTs were normal, but CT showed subtle irregularity of the right lobe with widened interhemispheric fissure. And here again, you can see that the ultrasound shows a slightly larger left lobe, a little bit of a fissure prominence. And here we are measuring the shear wave here and also doing a UGAP, and UGAP was 0.72. So again, we have values which tells us this is above S3 stage. The shear wave was 1.55, suggesting this is mild fibrosis. So here we could, now this was a case 3 with very low cholesterol values. Glycohemoglobin was high, but morbidly obese, 139 kgs. And here you can see again that the shear wave, this was fatty liver grade 2, as we would earlier call it, but the UGAP measurement was 0.89, very, very high, above S3 stage, and the shear wave value was normal, so there was no fibrosis. Now, this is another case, mildly enlarged liver, bright echo pattern with a UGAP of 0.80 above S3 stage, again normal 1.29 shear wave value. So this was the patient on, I think, arthritic patient with who was on methotrexate, and you can see that previous RFE value was 2.5. There was fatty liver grade 1. That time we didn't have UGAP, and now we have UGAP, which tells us that her fat content is 0.81. Her RFE value or shear wave value has dropped from 2.5 to 1.6. She has since stopped methotrexate since the last 10 years. So that has been a great advantage to her. And again, here you see liver, if we would have called it grade 1 fatty liver, but we are now having objective methods for quantifying this. Now, from a radiologist's perspective, this technique is not only limited to liver, we use it for breast, we use it for lymph nodes, for looking at evaluation of thyroid nodules, we use it for the parotid or any other mass lesion superficially accessible. We use it for prostate for guidance of biopsy. You can see there is a lesion here, highly vascular, and elastography shows it to be a stiff lesion. We use it for the testes to identify chronic abscesses. As you can see here in musculoskeletal imaging, in the supraspinatus, that's a small tear there highlighted as a white area and a red area on shear wave imaging. So these are a lot of other elastography techniques which can improve our clinical accuracy. It stretches the horizon of our imaging. Image guidance is important because, as I showed you in the previous slides, how can you take a measurement and rely upon it because you don't know where you're measuring it? You don't even know whether there is a vessel there. So I won't even today in 2021 call it point of care. I think it's very arbitrary, and I'm not sure whether we should really be using that technique. And additional information is provided, like a one-stop clinical assessment of risk. And of course, we have UGAP today, which gives us more information of fat content. Thank you very much for a patient hearing, and I hope there are a good amount of questions in our panel discussion.
Thank you so much, Dr. Lulla. This has been very a great presentation from you, sir. So what we will do is we will ask all the speakers to come on video. I can see yes, all of us are on. So we can get started with the panel discussion. I invite Dr. Abhishek Aggarwal to bring, he has a number of great points and questions which can be discussed across the panel. So over to you, Dr. Aggarwal.
Yeah, hello everybody, good afternoon. And after so many interesting sessions and lectures, there's so much of new information available that my mind is drooling with all sorts of questions. So we basically have talked about shear wave elastography and transient elastography, and everybody's there's a lot of audience question asking which is better or which is more accurate. But for the sake of simplicity, Dr. Nidhi, am I correct in inferring that ultrasound-based elastography is just transient or TE with eyes? I mean, it's just all the benefits of ultrasound-based elastography are mainly because we see where we are going, we see what we're doing, and if you don't get into the technicalities of the different machines or vendors or different vibration pulses, for a layman doctor who wants to refer a patient and doesn't know where to send, he should know that the main is just a fibroscan with eyes, right? They're not different sciences, they're not different technologies. It is just the same thing, the same information that we get, but under vision and without vision. And it's one is a blind approach and another one is a approach with ultrasound guidance, right?
So before I go on, congratulations, Chander. That was an amazing presentation. Okay, so I'm going to go on from our speakers, our faculty, and I'm going to pick up their points. Dr. Vivek Raj was very sensitive in picking up the point where he said that when we use transient elastography, our biggest factor, which is a limiting factor, is that there is a technician doing it. It has its pluses and it has minuses, but since there is a technician, there is hardly any, transaction of any information. Whereas when we are doing a shear wave, we have a radiologist doing it who can really give quality add information. So that's one Dr. Vivek Raj's opinion. And then Chander said, and which was a very important point, and you raised the same point, saying that vision, how are you going to go past that blood vessel? How are you going to go past that lesion? Or there was a question that was asked by Mridula Bapat, who's also doing transient elastography, and she asked a very specific question. Ma'am, can we do elastography in ascites? Yes, of course we can. Why? Why can we do it with shear wave elastography and not with transient? Because with shear wave elastography, you can always direct your beam or direct your pulse in a manner where there is no pocket of ascites. You can see it and you can put it into a place where you are completely eliminating that pocket of ascites. You can change the patient position. You can make sure that there is a little compression so that the fluid moves out, but you can't do that with transient elastography. So yes, in presence of ascites, we are still able to work our way through with shear wave elastography, even in presence of ascites, so that why we can actually modify our position of putting the
Dr. Nidhi, may I button, please? I have a question. Do we actually have data supporting this? Do we actually have data supporting this?
Yes.
Oh, yes, we have. We have. Yes,
yeah,
we have.
and the difference, I think, is also in the physics of things. I mean, the TE is more vibration-induced elastro, and this is radio frequency pulse, so it can traverse through water, unlike the TE.
Yes.
So that's the other
Yes.
difference.
Absolutely. Yeah.
And there's data available that suggests that
There
it's
It is not
possible.
just finding a window
So
with
then-
no fluid.
Uh-huh. Okay,
And
yeah.
then there was another thing, Dr. Dhar, there was another thing.
That's a
when I
very
said-
relevant point that Abhishek said, that say, because practically, clinically, in a large ascites, you will not be able to find a window with no fluid. So let's be practical
So
about
large
it. Yeah?
ascites is
So, but I
completely
understand what
different scenario.
Abhishek says, that if it's an ultrasound, then the sound, it's a sound wave, so it can even travel through the
yes.
fluid. So maybe you
Correct,
machine
correct.
can. Yeah, I think I buy that more.
But
Sorry.
let me also give you a caveat against ultrasound, is that if you've got large ascites, you really don't need a fibroscan. It's already a bad case of cirrhosis.
Yes. No, we just academically, obviously, if you have bad ascites,
No,
you have a large ascites.
if you have a large ascites, actually we do get reference for elastography because we
Yeah,
don't know
no.
whether cirrhosis is the cause or it's
Mixed ascites.
or
Yeah,
it's a renal
Yes.
issue. Or,
and there are mixed
we get
ascites
stuck
also.
there
Yeah.
sometimes.
Mixed ascites.
No, if there's no
Mixed
sign
ascites
of tuberculosis, then you know this is cirrhosis.
Correct,
So
correct.
clinically, it's quite relevant that if there is large
And there was-
ascites,
there
you
was
So
don't.
I have a
Another
question
question
for
that was
Dr.
there.
Dhar now.
Yes, sir.
Dr. Nidhi, let's go on.
Yes.
So if Dr. Dhar or Dr. Vivek, a patient comes to you with an ultrasound finding and which has classical gray scale findings of cirrhosis. Now after that, what role does elastography have in your mind? Would you still send the patient for an elastogram and to look for what?
Do you want me to come in?
Yeah, sure.
Yeah. So it will depend, a little bit of it will depend upon the etiology of the disease. See, if we are dealing with hepatitis B, hepatitis C, the information of the grade of fibrosis may be helpful. But then, if you are basically telling me that this is a shrunken liver with a portal, with obvious portal hypertension, and
Correct.
your ultrasound is, and there's fluid, your ultrasound is telling me classically that it's most likely a 4 fibrosis, then obviously I don't want an elastography. But there are cases in which you may just say there's a coarse ecotexture of the liver, the portal vein is like just there. In those situations, in hepatitis
So
B,
borderlines.
So hepatitis B, hepatitis C, yes, I would want to know the liver fibrosis because the therapy may depend on that. As Dr. Raj also mentioned in his presentation, especially in hepatitis B. So even somebody with a viral load less than 2000, if somebody has an advanced fibrosis, I would want to treat that person.
Dr. Lulla, would you want to give an opinion on this?
Yeah, no, I agree with it. It depends on the etiology, what exactly, whether it's a treatable condition or not a treatable condition. If it's a liver transplant situation, then we really don't want to measure the values. If it's treatable condition, you're trying to save the liver, then of course to put it in very briefly, as Dr. Dhar said, you need to monitor progression of disease with therapy.
But the risk for or the probability of clinically significant portal hypertension, would those values matter if say you get an elastogram value of plus 20, then the risk for variceal bleeding or the risk for progression to more?
No, these are additional points, but we don't rely alone on elastography values alone. We look at the overall picture. Like I said, it's
Correct.
a stepwise approach. It's clinical evaluation, the blood levels, the ultrasound, the Doppler, and the RFE.
And
So,
if you send me,
you should desist from making too many inferences. I would say just give the value, let the clinician make the inference of what he wants to do with that value. We do have a tendency to say this is this and do this and do that. But I think that sometimes it causes problems because the clinician's viewpoint may be a little contradictory. So from what I've gathered in the last 10 years is that people want only the value and they want the overall picture. They want a reliable value. They want the overall picture of the ultrasound, the Doppler. But let's not make too many inferences on imaging and let the clinician also do their job.
If you send me an
So suppose
elastography of 20, Abhishek, if you send me an elastography score of 20, I'll put an endoscope in.
Right.
Correct. But I do get follow-ups asking for elastography values in patients who are already frank cirrhotics, already 30, 35 values, come after a year just to know where the value is going. So I don't know how relevant that is.
Right. So I think I'll just put in there. So many times, as I said, the patients are using the information available on the internet and web and coming to you directly. So if a patient comes through me who has proven cirrhosis, has definitely, no reason for me to reassess. Now, certain situations where I have treated the patient with cirrhosis, for example, with hepatitis B or hepatitis C, where we have treated the patient after 2 years or 3 years, we want to see, is there some regression in fibrosis? In those situations, I might still send those patients for a proper assessment. But as a routine,
Dr. Raj, if I may interject, they come after taking these alternative therapies. They've taken homeopathy or they've taken something else, and now they want to, on their own, want to know what is happening with their CAP values, what is happening with their Young's modulus. So that is another reason when they're coming
The second question that we get asked in almost every patient who I see with cirrhosis, what is the percentage of liver that is damaged? So as I said, the human mind is very focused on numbers. And they said, what percentage of liver is damaged? Now, I can't tell him, I say, okay, it's child's A, child's B, child C, you have advanced liver disease, you have these features, that features. So many times they actually say, okay, but the radiologist, I went to the radiologist and they said, my value is this much, so this is 30% better or 20% worse. So I think that is one thing we have to sort of take into account, that it is actually they're focusing on the number.
Absolutely.
So as far as the radiologist goes, if a patient comes to me for an elastogram and I see that the liver is frankly cirrhotic, I do still go ahead and do the elastogram, not send the patient back, right? Because a baseline value is always important to have.
It is, yeah.
Yeah, very good. So there was a discussion about fasting before elastography and how many hours of fasting is required. What happens if the patient lands up just after a meal? Would you send the patient back or would you still do an elastogram? Dr. Lulla?
Yeah, no, we don't send the patient back. If the values are normal, that's fine. If the values are high, we would repeat.
So that's an important point to be for the audience, because if the values come out normal, so what fasting can do is probably give erroneously increased values. It can't give erroneously reduced values. So if the values are coming normal.
Abhishek, I'm going to interject here because there was a very big study that came out from Southern University, California. And this is in AJR. It's an AJR study of 2015, which is not really very far back, where they said they have done a study in which they have taken fasting state at 20 minutes postprandial, 40 minutes postprandial, 60, 80, and 120 minutes postprandial. And what they found was that between 20 to 40 minutes postprandial, the values actually fall. They fall. The elastography values fall. And then when they go on to do after 120 minutes, they find that the values rise. So it's important, and this is a very strong consensus that came out of that AJR, where it said, and it's in one of the papers, where it said that it is absolutely mandatory that the patient should be fasting 4 hours. Should be. Otherwise, you will always be lost if the values are falling down. Then you are always lost. So this is something that has to be taken into consideration. The patient should be absolutely fasting. And if I hadn't come across this study, I probably would have just agreed with Dr. Chander, Lulla, and yourself also that, don't send the patient back. And if they are high, then that is what is important. If you're having low values, you will always be lost there, where not knowing exactly where we stand with respect to the actual value. So that's a great study. I'm sure you should refer to it. It made a great read, very authentic.
Dr. Vivek Raj, suppose a patient who has compensated liver disease has to undergo a non-liver surgery, like a hernia repair surgery, and comes to you for a PAC clearance, then how do you assess and is there any role of elastography in you agreeing or not agreeing to let the patient be operated?
Right. So I think it's a very good question. So I think majority of the decisions in terms of when the patients come to me for what they call clearance, wrongly, it should be for risk assessment, is based more on the physiological parameters. So if the patient is child A, child B, or child C, what is the clotting, what is the INR, what is the albumin levels, taking that into account. So that is more important information than what is the extent of fibrosis or an assessment, whether it is by elastography or by ultrasound for that matter. And what is the extent of portal hypertension. So those are the more important parameters that I assess. So in that case, elastography is not something I rely on too much. As a attributable factor, yes, if that information is available, great. But if it is not available, I primarily want to look at the physiological aspects of how the liver disease is impacting, whether it is evidence of encephalopathy, varices, bleeding, INR, albumin, clinical ascites, or ultrasound-based ascites. So that is what I would rely on more.
I'd just like to add here that this is good for extreme severe conditions, but most of the times the gastroenterologist calls me up, the albumin is falling, can you please tell me what's happening with the liver? Or if, I'm looking at a slight varices on the gastroscopy and what's happening with the liver. So although clinically at the extreme, you're very sure that this is bad cirrhosis and bad clinical, the middle group where, your albumin is falling, you've got some leg edema, you've got some mild varices, there's a whole big spectrum of these cases where even the gastroenterologist wants the information, whether it's with transient elastography or with ultrasound-guided fibroscan. That's the majority of references we get from gastroenterologists.
So may I also interject here? So I would say that, it's when somebody comes for a risk assessment, I think it's more to do with the functional element of the liver rather than the structural problem. So elastography basically tells me what's wrong with the structure. It doesn't comment on the function, right? So I agree with Dr. Raj that even in my assessment, I would not give a lot of credence to elastography. I would want to look at the clotting factors, the ascites, the encephalopathy history, bilirubin, the CTB score basically. I agree with that completely. And if somebody has small varices, early varices or small varices, then until and unless proven otherwise, it is cirrhosis. And if somebody has varices and it's left-sided, if it's not cirrhosis, then it's either non-cirrhotic portal fibrosis or it's extrahepatic portal vein obstruction or left or sinister portal hypertension due to chronic pancreatitis or something else. So if there are varices, we have to look at the portal vein, and I think functional element is more important than elastography in that situation. I'm not interested in the structure. You send me a patient with an elastography score of 100, but if functionally the liver is doing fine, I'll give clearance for a surgery.
So I'm going to interject here again, and this is a question that I'm going to ask the gastroenterologist. There are a lot of times that you're also getting a lot of reports which say fatty liver grade 1, grade 2, grade 3. So as Dr. Dhar said, that you're not really going to put a lot of emphasis on the structure or the values that we are putting there or the grading that we are giving there. Will you be waiting for the functional element to go down before we take a call on it?
This was for a specific risk assessment before surgery.
Yeah, I understand.
It was a different clinical situation. So we are looking at a patient of cirrhosis. So absolutely. The ground line, the bottom line is cirrhosis. They need a surgery, comes for a risk assessment. It's a different ball game. We're talking about something else.
It is.
But if you send me an ultrasound, saying grade 1 or grade 2 fatty liver, no, I will not wait for it to deteriorate to grade 4. I obviously want to intervene early. I will ask for it. I will ask for a fibroscan or a transient elastography. I evaluate for the etiology. I'll get hepatitis B, hepatitis C done. Depending upon the gender, depending upon the age, the other evaluations, Wilson, ferritin for hemochromatosis, other things. I'll try and get an etiological diagnosis and things like that.
Our threshold for doing fibroscans or elastography has changed significantly over the last maybe 8 to 10 years. So if the same question was asked to me, the patient comes to me with fatty liver, will you get a elastography done or will you do a fibroscan? I would have said no, because it's expensive. It's not going to change my management. The patient is going to do exactly what we are supposed to do, lose weight, exercise, do this, that. But I think with more availability, more experience of using it, and better parameters now being available, we are using it as a entry screening for patients who come in with fatty liver, grade 1,
That's
grade 2, grade 3.
perfect.
Also,
Perfect
the other thing
message.
that has become clear now, which wasn't the case, say 15 years ago or 20 years ago, was that reversal of fat in the liver is number one
Yes.
possible. Number two,
Yes.
reversal of fatty liver disease. It decreases significantly and actually improves fibrosis score significantly. So it has
Right.
actually changed our paradigm of how we look at that. So I have a classic patient a young lady who had a breast cancer, had surgery and had fatty liver disease, was also on tamoxifen at that time. And she had advanced fibrosis, F3 fibrosis. In fact, ended up having a liver biopsy also because there was some suspicion that there may be something else going on. We then managed to get her off tamoxifen. She ended up having a oophorectomy because tamoxifen is one of the risk factors for rapid progression of
Right.
fatty liver disease. And she lost about 15 kilograms in weight. And the fibrosis score improved dramatically. And she ended up having another abdominal surgery for something else later on. And out of curiosity, actually, the surgeon convinced her to take a liver biopsy as well. And there was significant reversal of this advanced fibrosis on liver biopsy. So this is one of those anecdotal cases where we have
So
paired
Dr. Raj,
biopsies
up to
available.
what stages of fibrosis have you seen reversal? I mean, F1, F2, I mean, do early stages only go back or even
No, this
advanced?
patient had advanced fibrosis. She had F3, F4 fibrosis, but I don't know about the exact
Okay.
numbers. I also have another patient who actually was a classic example of how Hep C treatment affects. This guy had come in, Afghani patient with portal hypertension, gastroenteral vascular ectasia, and small varices, and we were doing APC every 3 months for him practically to try and stop the bleeding. And then we treated him for hepatitis C. At that time, we had pegylated interferon, and we were very scared of using it on somebody with thrombocytopenia. But anyway, we managed to treat him for a full year. He had sustained virological response with that, continued to come every 6 months, and then he disappeared. Came back 2 years later. His ascites had improved. His GAVE had gone practically. His portal hypertension had improved. And he didn't have the benefit of fibroscan at that time. But this is something that was one of the eye openers for me to say treating hepatitis C had reversed his portal hypertension significantly. So
That's
I think
promising.
that is where
So the important importance of surveillance in
right.
viral hepatitis so what are the I mean, you think elastography is a good mode for surveillance,
It
and
is.
how frequently should it be done, and what is how do these values mean to you when they come as follow-up? I mean, do you believe on absolute values, or do you believe in relative regression or progression of values in each patient? How do you interpret the elastogram, which is as a
So
follow-up?
for me, the values, absolute numbers are number one because many times they get it done from different people, different sources, different machines. So the value itself as an isolated number doesn't help me as much. What helps me is the trend. So there are situations where I've had patients doing as a follow-up every year, for example, we have done that, and the trend is heading downwards and the clinical improvement is also happening. I would be very happy to say, yes, you are getting better and the liver is getting better. And you will have one off value which will be high. And again, patient gets all worked up about it and said, no, we need to watch the trend. So I think in terms of following patients up with advanced fibrosis, especially, I do it once a year or so. Doing it more frequently doesn't help because they have not lost weight, they haven't done anything, it's not going to change. But many patients, when they have done the right things, you actually see improvement in those.
So if a patient
That's very
has reached the stage of SVR in a viral hepatitis, it must be a good idea to get a baseline study once the SVR is obtained, and then follow up
Right.
and see. And maybe not a bad idea if you could recommend that he or she should get it done from the same place and the same person for the sake of irregular or regularity. And that's why I think our report template should mention what, as Dr. Nidhi said, which machine is used and which probe was used and which technique was used. So for follow-up, we ideally use the same kind of equipment.
So like everything else, I think quality matters and standardization matters. So I think that is where whether it is the ultrasonographer doing it, a good ultrasonographer versus a ultrasonographer who's just taking 3 seconds to give you a value. Same thing with the fibroscan, a technician just doing it for the sake of it, or somebody who's a reliable technician who has been trained to do it properly. So those things matter. So does the machine and the equipment. So the more we take it out of the hands of of personal, I would say, more the machine takes over, sometimes the accuracy and the reproducibility increases in terms of the variability of the people.
So you mentioned lab values like APRI and fibrinogen for assessing fibrosis. Obviously, you would feel that elastography is more reliable to assess fibrosis than these. Over the period of years, you must have.
Yes, absolutely.
No
so
doubt
the sensitivity of those values and the reproducibility is much lower. So those are, I would call, a poor man's choice, number one, or non-availability. So at the same time, so because see, whatever we do elastography, and we are sitting in Delhi, so 3,000 rupees or 5,000 rupees, we sort of throw out like it's nothing. But when you actually look at real life issues, my friends who are working in smaller towns or with a poorer group of patients, for them to get elastography or a fibroscan is more expensive. They can't convince their patients to do that. So that is the situation where you can definitely use those lab values, which are much easier and cheaper. And you do not require to send the patient every time to Delhi to get it done. So if you are living in a small town, I have 2 patients who come from a very small town in Haryana. So I monitor them, they get their blood test, then they come back, they just show me the reports, and we make an assessment, a rough assessment based on that.
Is there a general rule for how frequently the surveillance should be done with ultrasound or elastographies or in a patient with viral or alcohol-induced hepatitis on management?
I don't think there are specific guidelines for that. Dr. Dhar might correct me for that, but I think we are using sort of what we learned from management of cirrhosis and HCC screening, for example, or the rate of improvement. So we sort of, my personal thing is roughly about a year if I'm just doing a regular assessment, but I don't think there are specific guidelines whether we should be using it more frequently or less frequently.
It also depends upon any deterioration in the patient's clinical situation.
Correct.
And so I would prefer to do an ultrasound 6 monthly, but everything else depending on the situation. Sometimes you would also want a CT and alpha fetoprotein.
Right,
And
so
coming to
your
coming to your question regarding the FIB4 and ultrasound and elastography, I think we can find a corollary in acute pancreatitis, the difference between a BISAP and a CT severity index score. So it's something like that. BISAP.
Okay.
Yeah.
I agree there. Dr. Dhar, may I just ask you a question? If you remember, you were talking about in post-transplant patients when we were talking.
Abhishek is the champion. You should ask him. He's the bond.
No, you're the person to whom the patient is going to be referred to
okay,
for an opinion.
Yeah.
So you elaborated a lot of investigative tools in a post-transplant patient who maybe suspect either inflammation, rejection, or maybe a recurrence of hepatitis or whatever. So how would you place, what is your experience, whether in elastography will be the tool, or would you want to go in suspect cases for a liver biopsy, directly a liver biopsy? You find there are deterioration of a few liver function tests there, because it didn't say anywhere elastography. So,
honestly, I don't have a lot of experience with liver transplant, post-transplant. That's an honest admission. But the second thing, if I look at this problem, so it'll again be more of a clinical decision. So whenever a post-transplant situation, so we always, when we ask a radiologist to come in or a radiologist follow up, as Abhishek is doing, is basically in the initial part to see whether any complications have arisen, like hepatic artery thrombosis or anything. And it will depend upon how the patient is doing, the clinical situation. The LFT will guide us, and that will decide what happens further on. Once the transplant situation is settled, the patient is on some immunosuppression, the liver functions are stable, everything is going on fine. Then in most of the situations, we are basically managing somebody with a normalish liver. I'm not saying a normal liver, but a normalish liver. And in that situation, the role of elastography is similar to the role of elastography in any other situation.
Before any other situation.
Yes.
Right.
Yeah. I just wanted to make a point. Abhishek, you must have done a lot of them. So when you do, we're not talking of the complications. No, I'm not asking, like Dr. Dhar said, there could be a thrombosis, there could be a ascites. I'm not talking of that. A normal liver transplant patient is coming and you want
consider it like a normal person. The same indications.
Yes.
Consider it like a normal.
Do elastography then?
Not routinely. I don't think so.
So
Not routinely,
unfortunately,
Abhishek?
we are bound by referrals. We do elastographies only if we are referred to do, right? So we see multitudes of post-transplant patients as coming in follow-ups. But we mostly end up doing ultrasounds or Dopplers and less of elastograms. But as Dr. Dhar is saying, that the importance or the values are more or less the same as with pre-transplant patients. I mean, it goes the same way. The amount of fibrosis.
Because today there is a consensus. And I think Dr. Lulla will agree when we come to shear wave elastography and post-transplant patient assessments. There is a consensus that you actually on a shear wave elastography can differentiate whether the patient is going for just a recurrence of the hepatitis or there is just mild inflammation. You have a lot of experience, Dr. Lulla. What would you want to say on this? That
No,
if we do
I think it depends on the etiology of the condition which caused the transplant. If the etiological factors are no longer there or relevant, then we really don't need elastography. I mean, we need to just monitor the liver. But if somebody has done a bypass and continues to smoke, we need to do a stress test. So similar to the liver, we need, if the exciting factors are yet there, then we will definitely monitor. As Dr. Dhar said, you have to monitor it as a normal liver. If there are going to be factors which are going to affect that liver, then we need to monitor. So whether it's elastography, CT, MR, ultrasound, all can be used. And I also want to add a point that in the risk assessment, although I do appreciate all the clinicians on the panel are saying I don't need elastography, I think in time to come we'll need all objective criteria. It's that one-off case which can really put you off guard and then you know that what went wrong. So I think it's better to put all the tools available as a summary statement for me, that please put all the tools available. Don't rely entirely, although you are extremely good clinicians, please be careful. We had
No,
I
Dr.
showed
Lulla,
you
but I
that
have a
case.
question here.
Can
I'm
I
sorry,
complete?
I have a question.
Can I complete?
Yeah, sure.
I had that case of extrahepatic portal hypertension who had varices, and he actually came for a liver transplant to Jaslo from Goa. And when we saw the liver was small because of extrahepatic portal hypertension. We did an RFE value. It was normal. And the patient then was said, is this normal? What are we doing here? So, and then we did a biopsy. It was normal. So the liver looked altered. There were varices. It's not going, I'm sure the clinician's judgment is always correct. But there is this one-off case which is going to, you don't get caught off guard sending a small liver for something which you can easily pick up on elastogram. So don't be rigid in saying that I don't use such a thing for clinical assessment. Open your mind and let use
so
all the modalities.
Dr. Lulla, for want of time, I will come back to basics. Dr. Dhar, if it's okay with you.
Yes.
I just want to cover some basics of elastography for the sake of the audience. First, Dr. Dhar and Dr. Vivek, you must have seen a lot of discussion about these IQRM values while we do an elastogram to keep them less than 30% for sake of accuracy. And that is something you should always see in any elastography report that you see from any radiologist, that how good are these IQRM values. Now, my question is there a similar sort of parameters in the TE elastographies that we do? Is there some sort of a quality parameter that tells you that the technician has done the job right?
The FibroScan reports also have an IQR. FibroScan reports also have an IQR.
The same IQR.
Same IQR.
Okay.
Just then, but it's there is just one value dependence.
So although, to be honest, most gastroenterologists don't pay that much attention to the IQR as we should. You end up looking at the CAP score
just the
and the
absolute
stiffness,
value.
LSM.
Yes.
And so that's why I think it's important for us to rely on fibroscans if it's being done the right way by the right person with the right machine. Because the fly-by-wire fibroscan providers are now taking the machine. One technician goes to every clinic and does 10 scans here, 5 scans there, 4 scans there. How often they are calibrated, how often they are reported, how good the technician is. So, for example, in our hospital, the vendor that we have been working with, we actually had 2 or 3 courts initially who came in with the courts, and we went through the whole process of screening them to say how many cases have your technician done, which is the technician going to come. We don't want three technicians coming on 3 different days. And how often are they calibrating the machines and recalibrating the machines? So I think that is important. So as I said, quality matters.
Dr. Raj, do we have an Excel probe available?
No.
It is now becoming available. They have now the vendor has brought in the new machine, so Excel probe will become available. I don't think it has arrived yet, but since our hospital has suddenly majorly opened up its doors to a lot of new technology, we have managed to get that also as a part of that.
Dr. Lulla, in real world conditions, how often do you have to send a patient back because you are just not able to get proper values?
Right.
Less than 1%. I don't think I've never really had no values coming up because the quality control methods allow you to select your areas very well. So we don't really, but if it's a patient very, very obese, extremely morbidly obese, I do have a problem sometimes.
But if the patient is not able to breath hold properly, do you face those issues?
Respiratory distress.
Not really, because it's such a fast technique that, most of the times you will get reliable values, and then you are looking at, again, the shear wave quality, you're looking at the IQR. So once in a while, yes, breath holding is a problem, but otherwise it gives values very fast.
But the machines which have only point shear wave and not the 2D elastography, there are some machines.
Then you rely on IQR.
2D elasters made things easier with respect
much easier. I was doing point shear wave for last 10 years, and I just got my 2D shear wave 4 months back, and I can see the difference.
Do you charge patients separately for a point shear wave or a 2D elasto? Have you kept separate?
No, I've discarded my point shear wave
all
machine.
New technology comes with a cost, right?
I've discarded my point shear wave machine, as you should discard your transient elastography machine. On a lighter note.
Well said.
Seriously, I've given the machine back.
Absolutely.
You have to change with the time. You can't.
In the talks of Dr. Nidhi and Dr. Lulla and the 2D elasto measurements, I saw a little bit of a difference where I saw that Dr. Lulla on your 2D elasto, you on a single measurement or a single box, you don't take a lot of measurements, maybe 1 or 2, and that's what I think the recommendation is, that the size of the box may be bigger or smaller, but ideally you should not take all 10 measurements on a single box. Am I right?
No. In fact, with 2D shear wave, you can take all the measurements in the same box. If the shear wave quality is good, you can take all the measurements. So that's what makes it easier. Yeah, you don't need to take multiple shear waves. So in fact, if you it's real time, so you don't really have to take another in the same volume, in the same cine loop. You can go back and forth, and you have multiple measurements possible in the same cine loop.
Absolutely. You just have to scroll down.
There was another question regarding the number of sites. If you're doing a point survey or a 2D survey.
No. You should take the same site. So in my report, like Nidhi said, you must always mention which site you have measured it before. So it can be different. Unless you're taking different sites and you're then documenting all the different sites, which is a bit cumbersome, but you will take the same site again. Maybe in the future somebody might publish a paper that I measured it at 3 sites and it was different, but till then we are measuring the same site. So I usually stick to the same site.
And even for your UCAP measurements, you take it from only one side, because fatty liver can be very, very heterogeneous.
No, I take it only from the right lobe 5, segment 5 and 6. It's easiest to take it there.
And what is your experience with pediatric patients with regard to elastography?
We have done a little bit of studies on thalassemia blood transfusion patients for ferritin overload. Not very encouraging. MR scored a little better, but we got good results. But we did a comparative study with MR and FibroScan and for ferritin overload, and that's where MR was a little better. For obesity, we are now getting a lot of childhood obesity and precocious puberty, and that's where we are doing liver fat estimation. And I'm getting shocking results. I'm getting a lot of morbid children with over 0.8, and it's really scaring me. I really don't know. So I'm hopeful that you clinicians can tell us more about this morbid obesity in pediatric patients.
It's actually rapidly increasing. Actually, in
Very rapid.
USA, more than 20% of children are
Absolutely.
obese in almost
But
many different school districts.
but does it
And in
lead to
India,
chronic liver disease?
it does, yeah. So it does.
25%.
Yeah, and even in India
Percentage is
now,
as high as 25% going on to becoming NASH.
and
No,
actually
but
my wife is a
pediatric population.
Pediatric,
my wife is a pediatrician, and she sees a lot of obese kids, which is very surprising. I mean, it's shocking actually. And in
But
fact,
has she seen obesity, the liver turning into chronic liver disease?
though that I don't know. I don't know the answer
That
to
is the
that.
key question, because we are looking at a lot of morbidly obese children, but I have yet to find whether it's
Because
it's
it takes
also
time.
it takes
So
time.
Yes, it will
it
take
takes time.
time. Yeah.
So by the time they are 25, they might end up with chronic liver disease.
Chronic
Is
liver
there a
disease.
role in diabetes, sir? Because of the correlation with diabetes and NAFLD, is there a role
Yes, yes.
for
That's
doing
a good
elastograms in
point.
diabetic patients?
Yeah, that's a really
Juvenile
good point there.
juvenile diabetes,
I
again, I would do fat estimation.
Even in adults, I think diabetics
Yeah.
should be screened routine.
Absolutely.
I think they should get a elasto or
Yes,
a
yes,
fibroscan
yes.
And
done. Yes.
dyslipidemics.
Yeah,
Dyslipidemia
they
is
should.
another one which should be.
Because NAFLD is a liver manifestation of the same metabolic syndrome.
Right.
No? So I think
Totally.
they should be. They should be.
Totally. And before we round up, Dr. Abhishek, there was a question. Somebody asked if we can differentiate between FNH and adenoma on elastography. And there was another question which said, can we differentiate between benign and malignant?
So that was
on
going to be my next
elastography?
question for Dr. Lulla. How is his experience in
Yes.
focal liver lesions?
No, I use contrast. We need to be very accurate in today's times. We can't. We have used elastography earlier, but there's considerable overlap. You can get hemangiomas, which are extremely fibrotic and
Yes.
giving you high values. You can get hepatocellular carcinomas, which are soft. So I think it's not accurate. We need to do contrast, ultrasound contrast.
And finally, any experience or recommendations for spleen elastography for?
Yeah, I think Nidhi spoke about one paper, a lot of interesting work being done there. And I think where they can predict the onset of varices and portal hypertension severity. But I mean, I'm not really very convinced, because it's a back pressure change you're looking at. It's the spleen has various causes of enlargement. And it's not a very specific, but yes, if you've got a portal hypertension situation, I would rather look at the liver directly rather than looking at indirect measurements of the spleen. So it's a good paper to publish, but I'd rather look at the liver directly.
If I would just make a point, that part where it says that splenic elastography is useful, that is only for one where there is a prediction whether there are esophageal varices and would they need. So varices with treatment. So those are the only two places where if you do elastography and you have a particular velocity and the KPA of greater than 16, so you can have a predictive value, and then of course you can go
how
ahead with
about a
as
patient
Dr.
pre and
Dhar
post
said.
transplant, Dr. Nidhi? The liver changes, but the spleen remains the same. Would there be
Yes.
physiological changes in the spleen after correction of say the primary cause by as being replacing the liver? So obviously the portal hypertension should improve, and so should the spleen
Absolutely.
values.
I totally agree there. So it's something which is probably in nascent stages, and we need to work on it a little
New
more
areas.
in order to bring more comprehensive a message across. But
So
I
as
do
Dr.
believe that
Lulla
it's
said, we should be ready for the change. As Dr. Lulla said, we should be ready to change.
Thank you, sir. Thank you very much. I really appreciate it.
बिल्कुल लग गई.
Dr. Dhar and Dr. Vivek, do you get confused by the amount of values of different vendors or different? You must be getting reports from all sorts of places. Is there any standardization of reporting templates that you see, or you see them variable, and that's causing confusion in your day-to-day practice?
We just look at the legend. You gave us a legend, I think. We just look at the legend.
Most of them give us a
Okay.
legend
So
saying
it's
that what is
important to
the
give a
estimate.
legend.
Absolutely.
I mean, there was a question amongst the audience as well asking for what is the proper template, and there has been a recent update by SRU, and they're quite keen on telling you that what all templates you should use and to simplify the rule of 4 that Dr. Lulla mentioned. I think that is very simple and very common to all vendors, and that is what should be used. So standardization of reporting templates for us radiologists is actually very important.
No, I think very important. Same thing for histology, for example. The reason Metavary score has come in, and because it standardizes that description, because 20 years ago we were not really sure about how to read the fibrosis, how to compare the fibrosis 30 years ago when Metavary scores actually came up. Initially it was just the Ishak score which was being used. So with the Ishak score and Metavary score now being standardized across all histological reporting, it has actually become much easier as clinicians for us to say what the pathologist is trying to tell us.
So Dr. Lulla, you must be giving the rule of 4, or do you still give the Metavare grading on your reports?
We do give the rule of 4. We give the SRU method, and we just give the value. And sometimes, if required, there are some clinicians, if it's not a gastroenterologist, they do want to know what stage do we correlate it with. So if it's from a physician and, lifestyle clinic where they want to change the lifestyle of a patient.
I think it's useful to have the F score, the F0, F1, F2, F3,
Both
F4.
of them can be.
Because actually, as a gastroenterologist also, it took me the first 3 years. I wasn't really sure what I was looking at when all this started coming out. Especially with the elastography, when it came meters per second, the moment it became physics, it became like, okay, it's out of my reach. So,
Aishwarya, please tell me when should we stop, because we could go on for hours. So, Aishwarya,
I think we should. I think we should stop.
So, firstly, amazing and very healthy discussion. Really good. It was really good sitting in the back and listening to all of you. Stalwarts coming from your fields, being able to talk about where, when, what, with respect to cirrhosis, fibrosis, what measurements to consider, what should be used. So thank you. This has been an amazing discussion. I would like to thank all of you for taking time out this morning, and we had a great audience attending, great questions coming in from audience as well, and a great response. So let's continue on the stream in the future. What I would like to tell the audience is thank you for attending, all of you. There is a poll question out to get your feedback on how this webinar was, so that we know to take this forward. At the same time, I would like the tech team to play the video. Today, the video that we'll be playing is to talk about how liver elastography and UGAP can be used in terms of liver diagnosis, both, as what we've heard from the speakers. So, tech team, you can start, and thank you all the speakers.
Thank you,
Aishwarya. Thank you very much.
Thank you, Aishwarya.
Thank you.
Hi friends, I'm Dr. Chander from Ria Clinic, Mumbai. We're going to do a workshop today on advanced elastography features on the new Logic E10 machine, new developments in liver fat estimation. As you know, today's steatohepatitis is a big disease almost similar to ethanol-induced hepatitis. So we will talk of ultrasound guided attenuation parameter for liver fat estimation. My transducer is absolutely perpendicular to the patient. That's very, very important in the intercostal spaces. Segment 5, 6, 7, 8, wherever we get a segment of no hepatic vasculature and no interfering other lesion. We then keep the patient in supine or left lateral decubitus with the arms outstretched so that the intercostal spaces are wide, and we tell the patient to have 4 hours of fasting, and we will make him suspend respiration when we are actually doing the new techniques. So the new techniques are, of course, one is liver fat estimation called UGAP, or ultrasound guided attenuation parameter, and it can be seen here here in these buttons here. And this is, of course, elastography. This is the new Logic E10 machine, and it has exceptional 2D imaging and color flow imaging. So usually when we do liver analysis, we start with color Doppler, and we look at all the normal vascular pattern of the liver to see whether there's any portal hypertension or any other vascular problem. Most of the patients where we do liver elastography will usually be patients with fatty liver or early liver disease where we want to see is there any fibrosis. So that's the hepatic veins here. We are seeing with radiant flow, which gives a 3D kind of cast-like image of the blood flow. And then once we have seen the liver, we always measure the right lobe liver. And then we see in transverse section, lamba swans le lo. So we look at eyeballing with the essential contours of the right lobe and the right lobe caudate lobe ratio. Lamba swans leke pakad ke rakho. So here, of course, the liver looks essentially just marginally bright. There's no evidence of chronic liver disease. So we will straight away go for the elastography. And the advantages are that we can change the ROI. We keep the ROI essentially parallel to the skin surface, that is perpendicular to the skin here and parallel to the linear surface of the capsule. So we take a segment, lamba swans, like this swans, but in the right lobe, which is free of any chod dijiye every chodo, and try to take it in expiration. If we get a good window, that seems to be a good window here. So we'll take a split image. Swans ban karo abhi, swans lena mat, swans lena mat. And you can see that we get a quality map. And we take over a few seconds, a few maps, a few images, and then we can scroll back and forth. So we on the left side image is the quality map, and it should be of uniform yellow color. If there are any spots, red spots, that suggest that we don't have a uniform quality shear wave. And you can see that we take the measurements in that box. You can take multiple measurements, and it's roughly coming in the normal range. So we get measurements both in kPa and meters per second. Swans ban karo. Chodo. And let's see what happens when we take it over the vessel. Swans ban, for example, will take a wrong technique. And you can see that the quality map is totally distorted. So this is a very good feature of this new technology, wherein which it tells you where not to take. And this is in comparison to something like FibroScan, because FibroScan is not image guided. You will not be able to identify an area which is not having vessels, and therefore there will be false results. Swans ban karo. So let's take this area now. Here again, we are having some vascular pulsations being transmitted. So we'll take another area again. So this improves the specificity of the technique. And in the past, wherever I used to get varying results, this was the reason. Swans ban karo. Now that's a perfect match, a perfect map. And we can see that we got a uniform yellow, uniform blue, but now there's one problem here. In the extreme top of the image, we can see that the circle is red. Now, when this is another check that the machine has, that if there is a red circle coming, that means that ROI needs to be rejected. The yellow ROI is good. So the first, although it's confirming yet to normal measurements, it's one of the quality maps, quality checks that is again there. So we'll take some more. Swas band karo. And again, that seems to be a good map, and you can see that it's of uniform yellow, green and yellow, the ROI, the quantification. And again, all measurements seem to be coming in the normal range. So we've taken about 8 measurements. We have saved the measurements, and let's look at the chart. So we've got a average median here, which is varying because probably because of the first measurement, which was a little off the mark, and we've got some extreme measurements. So what we generally do is 1 or 2 extreme measurements we will remove, and let's see what happens to that. So we're removing 2 lower measurements and 2 upper measurements. And now we have an IQR median of 13%, which is an acceptable range, and in kPa it's 25. So anything less than 30 in kPa and less than 15 in meters per second is an acceptable figure. We can yet take some more measurements and just to get a good average, because we have deleted some measurements. Swas ban karo. That's again a good map here. And we look at the final is about 16.4% and 8.2%. So this seems like a reasonably good result. It's 1.2 meter per second, which is normal. Now let's look at some other advances. The second advance that I'd like you to see is something called as UGAP, that is ultrasound guided attenuation parameter. It's very, very important to analyze the liver fat estimation. Now, we know that NASH is a big problem, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, and there are various stages of steatosis ultimately which precedes the stages of fibrosis. So fibrosis and cirrhosis are advanced stages, and we know that steatosis are stages before fibrosis, which can respond to lifestyle modification. So this is a new technique by GE in the Logic E10, and Swas ban karo. And just in a flash of a minute, we take multiple measurements of the attenuation parameter of the liver, and it can tell us what exactly is the liver fat estimation. So we'll take the same segments are taken essentially all the time. Swas ban karo. And we get an average value of about, values are in decibels per centimeter per megahertz. Now here again we are getting some extreme values, so we'll take a couple of more values because I think we didn't get a very good map here. Swas ban karo. And let's then take some extreme values. So, and then let's look at the work list. So we can delete some extremes again here. So 2 on either side so that the median remains appropriate, and we've got an IQR median ratio of about 28%, less than 30% acceptable, and the median is 0.52, which is just above the normal range, so probably just S1 steatosis, and of course we'll talk about this. So this is a very exciting new technology, and Swasband, and it in a flash of a couple of minutes, Swasband, you can see that we get the liver fat. So this removes the subjectivity of diagnosis of grade 1, grade 2 fatty liver. We actually have a value which tells us how much fat percentage is there in the liver, and this can be monitored over a period of time. So it's about 0.52. You see, I've taken multiple measurements, and it's yet the median is yet remaining the same. So we can get repeatability is good, and this can be followed up over a period of time, especially in obese individuals where we do some lifestyle modification, and then we can give them a value which they have a reference value, and over a period of time we see if there is any improvement in the liver condition. Okay. Mild fatty liver grade 1, and we'll do ultrasound guided fat estimation. So we have to tell you to stop breathing. Okay, so just stop breathing. Okay, breathe normally, and we have finished with all our fat estimation. His fat estimation is quite high, 0.8. So this is above the stage of S3, and we are median value of 0.80 with an IQR median of 1.6%. So not much statistical variation. Then we'll go ahead with the elastography. So again, we will ask you to stop breathing now. Stop breathing, stop breathing, stop breathing. Normal breathing. Yeah. Okay. We'll take your hand up, sir. We'll keep it up. Yeah, that's correct. And we'll stop breathing, stop breathing, stop breathing, stop breathing. Oh, perfect. Okay, so we saw that by the correct technique, raising his hand and suspension of respiration, we could get good values, and there seem to be normal values. So let's just check one more. Stop breathing, sir. Stop breathing. Okay, normal breathing. That completes our liver evaluation. So we have an IQR of 4.5% with a median of 1.29 meters per second. So there's no liver damage, there is no fibrosis, but there is excessive fat accumulation. So we are at the NAFLD stage where S3 steatosis, which can convert to fibrosis if we don't control our fat content. So
Thank you, everyone. Thanks for attending, and have a wonderful day. Thank you.
Thank you, Aishwarya. Signing off.
Thank you, ma'am.
Thank you, Dr. Lulla, if you're still
Thank you,
there.
Dr.
Dr. Raj.
Recording has
Dr.
stopped.
Dhar.